Good morning, my dear friends. There's still room in the front. I'd like to welcome you to the 35th Carim Symposium. This year is our anniversary, 35 years of beautiful Carim. I'd like to welcome you all to this fantastic day. It's a bit rainy outside, but it's warm and nice in here. A special welcome to our distinguished guest, Mary Cushman, who will give the Reneman lecture. Paul Shiels will give a keynote lecture after lunch. Special welcome to Harry Crijns, our previous director, after which we have named our most famous young talent program. Rob Reneman excuses himself. His physical condition does not let him to visit here today. He regrets it. It's the first time that he's absent, our founder, but he'll most likely will follow us online. Welcome, Rob, behind the screen. And with that, I would like to start my opening lecture. It's a bit about the highlights and the achievements of Carim in the years end 2022 and 2023. And while I was making this presentation together with the help of Danny Luciana and Tara de Koster, my managing team, which made it really slick this time, so you will enjoy it. I was actually thinking, this is my second round of being your director, fighting already 7 years against faculty cuts. We are only getting better. We're getting richer, we're getting more famous, we're doing better every year. And this is thanks to all of you, all your contributions, all your commitments, all your grants, all your PhDs that you deliver successfully. So thank you for that. And before starting, I would like to tell you that. So, Carim has a mission. It changes every year, not a mission, but the way we word it. Basically now we've decided to perform top cardiovascular research in a multidisciplinary team setting, which we think is very important, with the best, very importantly, also the most friendly researchers. We do not allow fights within our institute, although we have a war room. Regardless of sex, gender, ethnicity, or religion, we try and we do write plenty of grants to enable this, publish in top journals, of course, but also, very importantly, explain the meaning of it all to the general public. And also, as concluded by the ERC, the last ERC we had, the power of Carim lies in its ability to early detect talent. And we have many stimulation programs to help these talents achieving their academic careers. One of the programs, and I just already touched upon it, is the HS BAFTA, with a link to the famous UK BAFTA prize. And HS BAFTA, as I said, stands for Harry Crijns Award for Talented Academics. We have three kinds. We have the pre-PhD, the PhD, and the post-PhD or the postdoc. The first set is 1 year full break of your bachelor, second 1 year full paid break of your master to do research in one of the groups within Carim. We have a pre-PhD. After your master, you can prepare for a PhD, you can help writing a grant for a PhD, a stipend. Then we have, I think, the most important ones, of which we have plenty. That's like the 3 to 6 month break during your PhD. You can travel abroad, you go to a famous institute. We have a lot of contacts over this globe. And this is like really nice for exchange, cultural, scientific, and you come back, you're completely freshed up, and then you say, wow, what a great lab we have here in the Netherlands, because we have basically the best labs in the world, and you can only recognize this if you go abroad, for example, to the United States, where there's always like this very crowded old stuff in the labs, wooden benches. We don't have that here, so then you can count your blessings while being Maastricht. You can respond to that later, Mary.
Okay. My slides.
And then the postdoc is, we only have one, because that's the most expensive of the grants. That's a full year abroad at the institute of choice. And then come back, hopefully come back to Carim, or if you not come back to Carim, it's also fine. Then we have an ambassador in the world, always thinking about their beloved Carim Institute. Also like more senior talents, so we have our Carim talent track, so we help them during their career from assistant professor to associate professor to full professor. And currently these are the 7 in our program. Matthijs, Pieter, Bart, Job, Martijn, Miranda and Uyen. Uyen very recently got her PhD and we will certainly hear a lot more about her in the future. We have fresh professors. Andy Baker, at the end of 22, Roy Koenen, who just delivered his inaugural lecture last week, which was a great event. Roy was my first PhD student, so I'm very proud that he now made it to full professor. Miranda has been appointed this year. Ingrid Dijkgraaf has been appointed this year. She also already knows her date of her inaugural lecture. That will be the 22nd of March. And then there's 3 in the making. They're almost there, but they didn't get their appointment letter yet. And that's Dominique, Barend, and Henry. Also already some very small congratulations to them as well. But they will be appointed within a month, I would say. We have several organizations. We have almost 300 PhD students within Carim, which is an incredible amount. It's a very nice community, and their community is being governed by I'm Carim, and this is the PhD organization. It's a very active organization. Currently, Eline, Lisa, Laura, Minke, and Elias are the board of this fantastic group of people. They have made a Carim PhD guide. Last year was the first edition. This year was updated to 2023. All you want to know or questions you have about your PhD career is in here. It's a really nice book, and you can pick it up at our bureau, or the I'm Carim are visiting all the new PhD students in our institute to hand it over and then make acquaintance with the newbies. Last year, because also they made a fantastic recruitment movie for Carim, they were awarded the Carim Commitment Award, and this is the highest possible award you can get within our institute. They have a lot of activities. They tweet, or I should say X. They help you in choosing printers for your PhD thesis. They organize a lot of social events, as seen here on this slide. And you can contact them always. All their addresses, emails, and telephone numbers are in the Carim PhD guide. And they had specifically asked me today to inquire if there's any interest in joining I'm Carim, because they're looking for new representatives, and you can see the email I'm Carim at Maastricht University NL. So if you're interested, please drop them a line. So Carim has 3 divisions, and this is actually a unique combination of all the disciplines within cardiovascular disease. It's blood, vessels, and heart. There's nothing more to it. And in each of these divisions, we have 2 programs. Of course, they're not separated, they're not isolated, all work together in which I already mentioned, this multidisciplinary fashion. And in the blood division, basically we have venous and arterial thrombosis. In the vessels division, we have the vascular aspects of hypertension and diabetes and regenerative medicine. And in the heart division, we have arrhythmias and structural heart failure, which are currently more and more combined to electrical heart failure. We are really paralleling our research objectives with the clinical heart and vascular center from the university clinic, and basically they're perfectly aligned because of the emphasis on atherothrombosis, aortic reconstruction, and what I mentioned before, electrical heart failure. Also, complex genetics is underlying all these 3 divisions, and therefore Carim and the Heart and Vascular Center are really very nicely aligned. And we are one of the fine examples where this also works in a pretty good way, because we have now 4 really active translational lines. And there's the atherothrombosis, the aneurysm, the heart failure line, and arrhythmias. And they're supported by 4 infrastructural infrastructures, considering stem cells, imaging, the biobanks, and the data and modeling. And if you realize that these technical platforms are all based on human data and human tissue, so we're moving away a little bit from animal studies. Of course, we have to emphasize that animal studies will always be necessary. If we are working in multiple organ systems, then of course the isolated tissues or organoids are just a way of studying them, but we can never do without the animal studies. I would like to emphasize that. But this is based on all human material and data. I think this is one of the new things we're developing here within Carim, to get away a little bit from the animal studies. But also because we align Carim and the Heart and Vascular Center in such a nice way, we now decided that next year we'll fully integrate the Carim and the Heart and Vascular Center boards. Our 3 lines are now also fully supported by international clinical training courses. They're very well known by now. So for the blood, it's CASAM, it's the training for thrombosis, for clinical thrombosis. We have the European Vascular Committee, the school, that's from the vessel department. And we have, for the heart, we have the DASCAM, basically on arrhythmia. These schools, these courses are fully endorsed by the national and international professional societies as shown here on this slide. So if you have the time, visit our website. All the information I just showed you is on there, and it's a really nice and accessible website, as you can see here on the home page. Some key figures from 2022. So our annual budget, 21.5 million. It's pretty stable. It's always around 21 million euros. Last year, a bit low on new contracts and grants, 8.5 million. We have 11 clinical departments and 6 basic departments participating within Carim. We delivered a record amount of PhD defenses, 67 last year. All being supported and guided by 165 full-time equivalents of researchers, and supported, of course, by 54 supporting staff. Publications, more than 1,000, so this is really increasing. The average CNCI is 2.2, so twice world average. And if you look at the top 1% of papers, Carim has 3.4% in there, so that is going towards 3 to 4 times above world average. If you look at the grants and the money flows, here you can see from 2015 until today, you can see this is also with ups and downs. There's this trend toward increase, and this year we already have a top year, and we still have 1 month to go. So I think this is really going well for our institute. If you look at some of the grants, I only picked the ones that are larger than 0.25 million euros. We have some winners this year. I should definitely mention Stefan Heijmans, because he's like this year our grant winner, because there will be many more grants, and he has the biggest one here, 1.6 million. And then we have a lot of open competitions from Zonneway, which is also really rare because they're very competitive and difficult to get. So we have more of those. Here again, I can just show you the people that got the grants. So you see Stefan Heijmans again. Also Bart Spronk has a very nice, as a really junior early stage researcher, a very nice Horizon grant here. We got the triple grant from the UK, German and Dutch Heart Foundation by Koosmans, Koenen and Schoen. It's also a very competitive one. We got one of those. You can see many, many grants, and in total we are over 10 million already this year. There are also many prizes. You can see on this slide, Matthijs, Frederik, Rob, Sabine, Alice, Nikki, Michiel, Angela and Vanessa, Brian, Anouk and Fatma and her team. Congratulations with these prizes. It's always nice to have those, and I would encourage everyone, if there's such a prize, please inform Carim office. You'll be in the newsletter, and for us it's then also later very easy to recollect all these prizes, which you also need for our midterm reports and our external review committee. Some new visiting professors. Well, Peter Stenwinkel started already the end of last year, but he's still part of this year's visiting professor program. He gave the Reneman lecture last year, you might remember. Frits now finally accepted his invitation as being the chair of the International Scientific Advisory Board, and this Scientific Advisory Board currently consists of one person, and that is Frits. But together with Frits, we will decide how we're going to fill in this committee. And then recently, also Professor Peter Verhalme accepted visiting professorship for coming year within the division blood. So we'll invite him, and you will hear more of him. A little update on our binational, bilateral cardiorenal institute that we started with Aachen. This is a result of two very successful Horizon ITN grants that now came together, and the researchers founded a real institute. It is in Aachen. We opened the institute, and now there's a building being built of 40 million with support from the German state North Rhine-Westphalen. It will be a 5-story building, and the top 2 floors will be occupied by Amicare. Also, essentially, a animal experimental null institute. There will be an outpatient clinic in there, and we will combine researchers from Aachen, RWTH, and Maastricht, Carim, to work there as postdocs, as part of their PhD career, try to get grants through this, I should say, private enterprise that we now made between the two universities. Really special construction, and really excited to see this move forward. Organization of Carim. You can see this here. It is getting more complicated every year because we are installing more and more boards. And the green blocks you see there, I will shortly touch upon then after this slide. But basically, the show is run by the executive board, and the executive board is also expanding every year. We're getting input from the Education Program Committee. We're getting input from the Research Council. We have a grants and incentives team that have actually a representative in the executive board. We have a strategic board that delivers a representative in the executive board. We have the diversity and inclusivity board, which is also represented in the executive board. We have our support personnel organization, which was founded last year by Sandrine Seijen. And I'll tell some more about that also later. And we have the I'm Carim PhD organization that I touched upon before. Under the executive board, we have our 3 divisions with our 6 programs, and here we have the 15 departments, and also working together with our education program committee. And then all the members of these programs and departments are welcome at our school council that we have every 3 months, discussing all the current topics within Carim. You see the Research Council consisting of those persons, and they give the executive board advice, ask for and not ask for, and you can see the topics that they have touched upon this term or this year. We have the grants and incentives team. They keep us up to speed with all the possibilities of grants, and they're open for positions this time. So if you would like to join the grants and incentives team, please send a mail to Carim office. And then we have the strategic board, and as the strategic board also advises and supports the Carim scientific director and the executive board in managing long-term policy, and they inform us on current trends and also important missions that we should not miss in the future of Carim. And also there are positions open, so if you would like to join this very important committee of Carim, please send an email to Carim office at Maastricht University.nl. The Carim Diversity and Inclusivity Board, we had a very nice, in the end of last year, a very nice meeting in our cinema here in the city center, looking at Picture a Scientist, which is a well-known Netflix movie. If you haven't seen it, please look at it. It shows the injustice that happens within the diversity and inclusivity issues. In this case, in American universities, but it's a must-see for everyone. We discussed this, and there was a really fruitful afternoon because these themes should be discussed basically every day within our organization. Strategic initiatives, as said, we're doing well, so we have money to spend on all these nice initiatives. So we support our expert group on cardiovascular data sciences. We have some budget for our diversity and inclusivity group, so they can invite speakers and organize lunches and events. We're going to launch a PhD call in 24, so you can already start thinking and writing about proposals. We have a fully new Carim postdoc program, our own VD, so to say, 4 years, fully paid with a bench fee, which is about more than $500,000 we're going to invest in that. And then we got a new initiative which is called the Anna Maria van Schuurman Stipend, and this is a female staff stimulation stipendium that will be active as of next year. And this is an annual support stipend of 100,000 euros. And there's more in the making, but I can't tell you about that, but I'll show you this next year. So, who is Anna Maria van Schuurman? Well, in contrast to all beliefs that Aletta Jacobs was the first female student allowed to university in the 19th century, actually Anna Maria van Schuurman was allowed to join Utrecht University already in 1636. Anna Maria van Schuurman was a Dutch scientist, humanist, engraver, painter, poet, and writer. Basically, she could do anything. She spoke 14 languages fluently. She could do anything like paint, engrave. She was a humanist, but also a scientist. She's basically a wonder woman. And this is actually some work from our hand. And this is, of course, like in that time, really unique and novel. The dissertation on the aptitude of the female mind for learning and the fine arts. But this is like still very interesting stuff, and this is very old. And the first English work is The Learned Maid, or Whether a Maid May Be a Scholar. She was invited to write a poem for the opening of the University of Utrecht in 1636. And I have some lines on that. It's in Latin. Frits can read it. I can't, but ChatGPT made a very nice translation of this Latin verses. And this is line 15 until 21, and basically you can read what it is. People can enjoy the new knowledge that they can take in from the university in Utrecht. But then the last two sentences, of course, are the essence of her fight for female recognitions at the universities. But you might ask, what is troubling you? Well, these sanctuaries are inaccessible to women. She said this during the opening. And by doing this, she was allowed to follow classes at the University of Utrecht after it was founded, but she had to sit behind the curtain to not distract the male students too much. So we thought in honor of her, and being also the first student, we thought like this stipend would be in place carrying her name. So we'll start this next year. And we'll tell you more about the criteria for that, if it's only junior staff members or that also full professors can apply for this grant. But you hear more of this later. Then we had many highlights. We had our beautiful lustrum anniversary party in a castle. We had a lot of fun. Came very late. I almost made it to 1 o'clock. Other people made it even later than 1 o'clock. The pictures are really small, but you can still find them on the website. We had everything. We could gamble, dance, drink, eat, anything that's forbidden we did there, and that was really a nice evening. So looking forward to the next 5 years. So in 28 we'll have also a new blast party, and we'll start preparing that tomorrow. We had, of course, our public events, walking with doctors, patients, researchers, doctors, 5 or 10 kilometer walk. It's an annual thing. This year we had a record check of more than 60,000 euros, which is all being put in the Health Foundation Limburg, from which also research projects are then being founded. we had our World Thrombosis Day. This time we had it in the city also with a flash mob. And I think if I click this, this will start. Will it? Doesn't. How do I do this? Tara? Doesn't work. Maybe if I do this. No. Huh? Oh, it's on a pointer. That's the thing. To go back to the... Oh. Okay, well, it was a beautiful flash mob with a nice music. We won't see it this time. This always happens. This is also very successful. We are doing this every year since the founding of the World Thrombosis Day. I think it's a very important day to make society aware of the importance of doing research on thrombosis, and also let them know what are the signs and what should they look for if they are afraid that they have or get a thrombosis. Mens sana in corpore sano. Carim also engages in many sports activities. This is our second longboat rowing contest. And you can see the team here. Here you can see the longboat. You can see it's in second place, but sometimes we're actually able to overtook these small boats. And if you realize that this small boat is only 60 kilograms and a longboat is more than 600 kilograms, I think they did a terrific effort. And you can see in the end, they also won the first prize. It might help that there's only one longboat, but still I think this is a fantastic achievement of our team again. We also engage in running. This is Maastricht's mooiste, 10 kilometers, and here you see the team that runs the tech. So we are really, this is just some of the highlights that we did, basically on physical activities and social activities we have as well. And I just would like to remind you on the Carim Café, every first Monday of the month in Saam, there's free drinks and free bites, no cocktails allowed. And you can just discuss with your colleagues and friends about culture and science. And it's always, there are between 20 and 50 people, but considering the fact that we are more than 500 within Carim, I would like to invite you to come there more often. It's really, really nice. If you have come there once, you'll be there again. And with that, I would like to go to the beautiful program today. Here you can see the very nice front of the invitation, and on the back you can also look at all the previous Robert Reneman lecturers, which is a stiff collection of great and beautiful scientists. And we have a very good program. Seen here, you all have it on the cards. And with that, I would like to invite Blanche as the moderator of the first session at the stage. Thank you for your attention.
Well, thank you so much, Tilman, for this wonderful introduction to an exciting day. It is my pleasure to chair this session with hosting some of the talented researchers that you have already introduced. The first one being Sam Heuts, who won a Heart Foundation Decker grant for his research around cardiothoracic surgery and the damage that may be done that way. So the floor is yours.
Okay, I have a movie, but I think it will work. Thank you very much for the introduction, and I also would like to thank the organizing committee for the invitation to present our research here and our DECA project. And this is entitled, with a hip acronym, of course, PRIMARY, which means postoperative biomarker measurements after coronary bypass surgery. And in this project, we aim to improve our understanding of the concepts of peri-procedural myocardial injury and infarction using biochemical measurements and state-of-the-art imaging modalities. Well, a short introduction about myself. My name is Sam Heuts. I completed my PhD at Carim in 2019, and I'm in training to be a cardiothoracic surgeon. And this year we received the DECA grant as a clinical scientist on the subject of perioperative myocardial injury after coronary bypass surgery. And this is specifically done in a multidisciplinary team. And this team, I have to thank them a lot for the support in getting the grant. It consists of my own department, also the Department of Radiology and Nuclear Medicine, and Professor Maas and Professor Wilberger will serve as the PIs of this project. But we have very close ties with the Department of Clinical Chemistry, Intensive Care Medicine, and our colleagues of the Cardiology. So many thanks to them. I would like to start with a short video in which you maybe can see the controversy that exists in our cardiovascular and surgical community regarding the subject which I'm talking about. And this is actually a snippet of a video from BBC Newsnight of 2019, in which a video recording is displayed of a congress in 2018 in Lisbon, our European Congress, in which really some professors got into a fight during the meeting, and I just wanted to show this to underline the controversy that exists at this moment.
This is a story about fights and controversy in the medical community.
It was never discussed with me. It was never discussed with me.
About a clinical trial that failed to publish some of its results.
Knowledge of that information would, in my personal opinion, make a genuine and substantial contribution to our ability to appreciate the nuances of the results and the inconsistencies that are observed.
Data that doctors think should have been published.
To appear to claim there was no difference between these two groups, I thought was dangerous for patients.
Results that change the guidelines that doctors use to treat the heart.
They are unscientific. This is not a robust and safe recommendation.
So this was for everybody open to see in BBC. You can imagine this sparked a lot of controversy in our community. And before we delve into that problem, let me just tell you something short about coronary artery bypass grafting, or CABG, or coronary bypass surgery. This procedure is a surgical procedure which has the aim to reroute blood to myocardium that is at risk of ischemia due to proximal coronary stenosis. And we perform this procedure by opening the chest, by implanting a heart-lung machine or the cardiopulmonary bypass system, and we seize the heart actually for about an hour during this procedure. So in any patient, all the time, this is a highly invasive surgical procedure. And if injury is inherent to the operation, this poses some difficulties in defining which injury is normal and is inherent to the procedure, or which injury is actually too much, when is enough. Well, some of the things we can't avoid are mechanical manipulation of the heart, so we really grab the heart, the implantation of the cardiopulmonary bypass system, or the cessation of the heart during cardioplegic arrest. These are unavoidable mechanisms of injury. But there are also more avoidable mechanisms of injury, such as reperfusion injury or damage to the native coronary artery or to the graft. And this takes us to the problem. Because the problem is that injury is inherent to the surgical procedure, but it's a slippery slope to define when the injury is too much, enough is enough, and we are talking about a myocardial infarction. And because it's such a slippery slope, several definitions exist, which are three are the most generally accepted. I'm not going to walk you through these definitions, but they are very contradictory in some critical aspects. First of all, which biomarker should we measure to evaluate the extent of injury? Is it the MB isoenzyme of creatine kinase, or is it cardiotroponin? I'm not even going into the troponin I versus T issue. Which threshold is diagnostic of an infarction or too much injury for those biomarkers? And the last one is, do you need supporting evidence? And what I mean by that is, can you diagnose a myocardial infarction after surgery just by biomarkers alone, or do you need supporting evidence in terms of electrocardiographic or echocardiographic support? Well, I think many of you will think that CKMB is actually quite outdated, and it's true. Cardiac troponin is proven to be superior to CKMB in patients with primary myocardial infarction. due to its superior prognostic value. But during CABG, so during surgery, there are several non-necrotic or non-ischemic mechanisms that also lead to cardiac troponin excretion. And this can obscure the actual estimation of injury, and it makes it more difficult. And maybe that's less the case with CKMB. So if we are looking only at post-surgical patients, studies actually show conflicting results on the diagnostic accuracy of these various biomarkers. Well, this is for sure not just a problem in Maastricht, not even in the Netherlands, but it's really an international problem, and there's inconsistency and lack of consensus, which is maybe illustrated by this figure. In this figure, you see the 15 heart centers in the Netherlands who perform cardiac surgery, and you can see that all measure different biomarkers or different combinations of biomarkers, and I'm only focused here on cardiac troponin in general, but the different centers also can measure I or T. And I have to stress that I didn't even incorporate the thresholds that the different centers apply in this figure. So this calls for action. This is a particular problem, not only a matter of semantics, but it's also a problem from a patient's perspective. In the graph on the right, you can see what happens if you apply a different definition to the same sample of patients. This is a study of 5,000 patients, and if you apply one of the definitions, the perioperative myocardial infarction rate in the CABG group is 1.9%, and in the same sample of patients, if you use a different definition, it's 18.3%, 9 times higher. And this leads to over and underdiagnosis of perioperative myocardial infarction, and that is harmful because overdiagnosis leads to unnecessary invasive diagnostics with potential complications, while underdiagnosis unjustly withholds adequate and timely therapy for these patients. This in turn reduces prognosis, increases hospitalization and costs, and it also poses a psychological burden on the patient. There's a direct relation between the etiology of the injury and between its treatment. Some of the unavoidable and irreversible mechanisms, such as mechanical injury or inadequate cardioprotection, can't be reversed and can't be treated, so this is treated conservatively. But for the reversible causes, such as a problem with the graft, or a problem with the anastomosis, or a new native coronary problem, it can be treated and it should be treated as quick as possible. And in general, we know that early, timely, and adequate diagnosis and treatment is imperative to preserve as much viable myocardial as possible to improve the prognosis. There's also an academic side to the story, which also influences, in the end, the patient, and that is actually the video that I started with. The video was centered around the publication of the results of a trial which compared stent placement to coronary bypass surgery. And the primary composite endpoint after 5 years, death, stroke, and myocardial infarction, didn't differ significantly between the groups. And PCI and CABG, so stent and surgery, were deemed equal. But if we look at the definition of perioperative myocardial infarction in the trial that was applied, it seemed to actually favor stent placement. We can see that in the top right. Well, in the lower right of the figure, we see what happens with the myocardial infarction rate if we use another definition. It decreases significantly in patients undergoing surgery, and it increases in patients undergoing PCI. So in the original analysis, there was no difference in the primary outcome, and stent placement and surgery were deemed equivalent. Well, if we would have used another definition in this trial, the primary composite endpoint would lead to the interpretation that surgery is actually superior and PCI stent placement is inferior. I'm not saying one of the definitions is better than the other. I'm just stressing the importance of the used definition and how it can affect the patient, because the results of the original trial were implemented in the 2018 guidelines for myocardial revascularization, and stent placement and surgery got an equivalent recommendation, class 1 level of evidence A. Well, because of all the controversy and the BBC Newsnight broadcast, a task force was installed who reviewed all the evidence, and actually last month, stent placement got downgraded to class 2A in this specific patient group. And this brings me to our proposal to improve this. The aim of the primary project is to redefine the diagnosis of perioperative myocardial infarction as a diagnostic entity. And we want to do this to prevent under- and overdiagnosis, to increase the efficiency, or in Dutch, the doelmatigheid of the care for the CABG patient, and to improve patients' prognosis. And we aim to do this by conducting 3 studies with various designs, which are all 3 incorporated in the primary study. Our center and our university will serve as the leading center, and we will join forces soon with the Catharina Hospital in Eindhoven and the Leiden University Medical Center in Leiden, both in the Netherlands. And the first study is aimed at the identification of patients with postoperative myocardial injury and infarction using a golden standard. And golden standard for this project is cardiac MRI, which I'll come back to in a second. We want to relate the findings on the MRI to the biomarker concentration increases and their dynamics, and correlate this to the imaging findings. And if we look in a flowchart, this looks like this, which looks quite complex, but I'll walk you through it in a second. First, patients with multivessel disease will be included with a preserved renal function and no recent myocardial infarction. And they will undergo standard clinical workup, including invasive coronary angiography, echocardiography, and baseline ECG. But for the study purposes, patients will also undergo preoperative cardiac MRI with delayed enhancement and coronary CTA, also with delayed enhancement. Shortly thereafter, we will perform the surgical procedure, which will consist of coronary artery bypass grafting on pump with cardioplegic arrest and multivessel revascularization. And patients will be admitted to the ICU in our ward, and in the first 72 hours, we will intensively sample various cardiac troponin assays and CK and CKMB. And on the 3rd postoperative day, patients will again undergo a coronary CT, again with delayed enhancement. And the primary outcome of this study is actually at 30 days post-procedure, which consists of the new postoperative cardiac MRI with delayed enhancement. Well, for the imaging part, we expect, based on available literature, that around 40 to 50% of patients will have objectifiable injury on this MRI, and we will also confirm this in a follow-up study after 1 year. So in the patients with injury at 30 months, the MRI will be repeated after 1 year. Well, this requires an intensive sample size calculation. We expect a prevalence of myocardial injury on MRI of 40 to 50%. Difference in sensitivity between CKMB and troponin of 20%, a dropout rate of 10%, standard sample size calculation power and 2-sided alpha, and then we need 51 patients with myocardial injury, which translates to 128 patients that are required to undergo both scans, pre- and post-operatively, and when corrected for dropout, this means 143 patients have to be included beforehand. As you can see, there's a lot of imaging in this study at various time points using different modalities, including invasive coronary angiography for all patients, coronary CTA with delayed enhancement pre- and post-operatively on the new photon counting scanner, pre- and post-operative cardiac MRI, and cardiac MRI after 1 year in 50% in patients. And this also facilitates various sub-questions. The main question, of course, is the difference between pre- and post-operative late enhancement on the MRI study, which then will define the procedural injury. But we can also compare the 30-day and the 1-year MRIs, the preoperative invasive angio, which is the golden standard for quantification of stenosis severity, to the coronary CTA preoperatively, delayed enhancement on CT versus MRI preoperatively and also postoperatively. So a lot of chances here. The question is if the injury that you observe, if it's clinically relevant, because I don't think that 50% of patients truly has a myocardial infarction if you observe some injury on their cardiac MRI scan postoperatively. So the second study is actually aimed at the identification of the relation between biomarker concentration increases and imaging findings and clinical events. And we do this by evaluating the clinical relevance of perioperative myocardial injury. The flowchart stays the same, but the outcome varies now. After 1 year, the outcome is a 1-year follow-up evaluating the cardiac MRI findings, mortality, and major adverse events. As you can see, it's quite a time and cost-consuming trial, and it heavily depends on the sample size and the event rate. So we also proposed a third large retrospective study in which we merge the databases of 2 international academic centers, including our own. And this database contains complete postoperative biomarker concentration follow-up and clinical event follow-up, including mortality, major adverse events, and unplanned revascularization. And this is a collaboration between our center and the University of Innsbruck. We've coined the term the Maastricht initiative for this cooperation. And we plan to merge the data of 6,000 patients operated on between 2010 and 2020. And we will apply various statistical methods to evaluate the prognostic value of the biomarker increases on 30-day mortality, 1 and 5 year survival, and major adverse events. And by doing these 3 studies with various designs, we can actually, I think, answer our main research questions, which are diagnostic and prognostic, as said. A lot of secondary research questions, and some of them I've named, some of them I didn't name yet. Too many to address now, but I would like to end with maybe the ultimate goal of current medicine and also this project, and that is the development of a clinically applicable patient and procedure-specific model to predict the expected biomarker release in patients undergoing the procedure. And we have made a start with this in our department, and it looks like this. We enter the characteristics of the patients and the procedure, so the age of the patient, the duration of the procedure, the number of bypass grafts, and the model can formulate the expected temporal evolution of the biomarker, and it can relate to the biomarker concentration of the patient at that time, and we know if he is deviating or not from the predicted course. So our medical ethical committee approval is in the final stage, and I think we can conclude that there is a lack of consensus regarding the definition of perioperative myocardial infarction, that it affects the patient's prognosis, and that this research project can serve as the foundation for refinement and standardization of the diagnosis, and that will eventually improve care for all patients with coronary artery disease, but patients undergoing the CABG procedure in particular. Thank you.
Thank you so much. That was a wonderful lecture, the speed of light. So lots of plans you have, and I'm sure there are many questions. Who would like to kick off? I also thought I would have some help with throwing the mic, because I already, great. Thanks, because I'm not that good at throwing. Boy, can I do that?
Not sure, yeah, it's working. Some congratulations, very nice project. Talking about the second study involved, you're looking at clinical endpoints, which is really, like the word says, an endpoint of a pathophysiological process. So are there any opportunities to look previously or earlier in the time frame for subclinical changes in cardiac function or whatever? Because maybe you can pick up earlier signs of already a pathophysiological process which is then starting and leading to the endpoint.
Yeah, so our protocol allows for this to be possible, but it's not incorporated as a prospective methodology. So patients will undergo echocardiography at our department and the various referring departments. We can use these data, but it's not standardized for the study because we have focused on the 1-year MRI. And I have to say the 5 scans, which are all non-clinical, are already quite costly. So we will obtain permission to use the echocardiographic data, but it's not prospectively defined.
Other questions? Leon?
Great presentation, Sam. So, a question, all patients are unique. Do you also take into account that coronary artery disease is also often linked to peripheral artery disease or carotid artery disease, and whether or not this can also influence your outcome? And the second question is, do you think that a power of 80% is good enough, or should it be 90% to really pinpoint specific patients?
Thank you. I agree that there's a lot of variability in the risk profile of these patients. And we actually also see that it influences biomarker release. So higher risk patients, for example, with peripheral artery disease, tend to have more release of CKMB and cardiac troponin. The question is whether that's because of their risk profile, because of more heavily coronary artery disease, which is also related to the peripheral arterial disease. We don't know, but we can adjust for these things in the model which I have showed you. So the model will correct for this, and it will also predict a higher release of biomarkers for such high-risk patients. And your second question was regarding, I think, the 80% power, which I have to say, if we would increase it to 90%, we would have needed double the patients and double the funds, which are already difficult to obtain, I have to say, because the funds for the imaging studies are not incorporated in the DECA grant, which is only for salary. So we're already fighting to get enough funds for 80% power.
Making this concession, do you really think then you find a difference between biomarkers?
I genuinely believe that we will find differences, yes. And even if we wouldn't find differences, even if the diagnostic accuracy is completely the same, this is also an important result because it means that centers around the world can use both biomarkers and it doesn't come at the cost of patient care. And even if we don't find a difference, we will find concentration thresholds that are optimal for diagnosis, which are at this moment only based on expert consensus. There's no study with a golden standard who has investigated this clinical problem.
Okay, thank you so much, and great stuff for further discussions. Thanks again, Sam. And with that, I would like to introduce Rob Holtakkers, who actually in the Institute we already identified as a talent because he got a Kortstra fellowship, but now he even improved that achievement by getting a VENI. And the title of your talk is Interventional Cardiac MRI, a new strategy for improved diagnostics and treatment of cardiac arrhythmias. I know a little bit about it, and I'm looking forward to your talk.
So good morning, everyone, and thank you for the kind introduction and also for the invitation to speak here. It's actually a pleasure to be back here in the location where I defended my PhD thesis last year with much blood, sweat, and tears. And I see some of the defense people are here again, so please keep me alive. But today I will present on my recently awarded VENI grant application, which is about interventional cardiac MRI, a new strategy for improved diagnostics and treatment of cardiac arrhythmias. So I think, as most of you know, cardiac arrhythmias form a major and increasing health problem in adults and have a drastic impact on people's life. And every year, almost 450,000 people in the Netherlands are confronted with some form of cardiac arrhythmias. And that is almost 4 times the inhabitants of our beautiful city of Maastricht here every year. But fortunately, these cardiac arrhythmias can often be treated using catheter ablation therapy and by either cooling or heating the heart muscle tissue using ablation catheters. Local tissue damage is induced so that the electrical impulses that cause the disorder are blocked. These ablation catheters are guided from the groin to the heart under fluoroscopy guidance. However, fluoroscopy has significant drawbacks, such as its potentially harmful radiation dose for both the patient but also the healthcare employees, and the limited soft tissue contrast. But more importantly, the treatment is often not successful, leaving the patient with symptoms which require the patient to undergo ablation therapy again. Various technical innovations have recently made it possible to perform ablation therapy while the patient lies inside an MRI scanner. And since MRI scanners do not use harmful X-rays, the entire procedure can be performed radiation-free, benefiting both the patient and the employees. However, since MRI has only been used as a pure diagnostical tool so far, extensive modifications to the existing MRI system and the scanner room were required, for which we wrote a business case in 2019 already. After approval of this business case, we started transforming one of our existing clinical MRI scanner rooms into an interventional cardiac MRI suite that is suitable for performing these cardiac ablation therapies. So here you see some pictures of the preparation of one of our patients just outside the scanner room, where the patient is being intubated and venous access is created for the catheters. Following the preparation outside the scanner room, the patient is brought inside and inserted into the MRI scanner. Here you see some more pictures of further preparations when the patient is already inside the scanner. The system is being draped to create a sterile environment, and the catheters are being connected to the technical equipment. So using MRI, we can now accurately access the anatomy of the heart directly before the procedure to create a high-resolution 3D model. And by using special MRI-compatible catheters and advanced 3D imaging techniques, we can now accurately visualize the location and the orientation of the catheters in the heart in real time. So this allows for better navigation and improved positioning of the catheters compared to fluoroscopy, which may result in a more accurate procedure with a lower risk for potential complications. By displaying the electrical signals of the catheter onto this 3D model, we obtain direct feedback on the conduction of the electrical impulses after the therapy. And although it's clear that we can now safely and effectively perform cardiac ablation therapy inside an MRI scanner without using these potentially harmful X-rays, with much better soft tissue contrast, the real advantage of MRI lays in its unique imaging opportunities in terms of tissue characterization. By imaging directly pre- and post-ablation, we can now visualize the ablated area and access changes in tissue characteristics. For example, in the presence of edema and changes in parametric tissue mapping. And after contrast administration, we can also evaluate the ablated tissue even further by measuring tissue perfusion, as well as contrast uptake in the affected tissue. The big question remains, however, can we, by visualizing the heart more clearly, treat the patient more effectively? And we don't know that yet. And that brings me directly to the goal of my VENI project. So for the first time, I will investigate whether local tissue changes, as measured using MRI at the time of ablation therapy, correlate with procedural success. So how do I going to do this? So first of all, I will perform follow-up MRI imaging at 3 and 12 months post-ablation in every patient that undergoes cardiac ablation therapy inside an MRI scanner. And hereby, I can create additional insight into the healing and remodeling of the ablated tissue. Using the earlier mentioned MRI tissue characterization methods, I then aim to distinguish between transient and persisting tissue changes during this follow-up imaging. By correlating the persistent tissue changes at 3 and post months post-ablation with the imaging findings directly post-ablation, immediate quality control of the ablated tissue during the ICMR procedure is within reach. As a result, the operator can then confirm that permanent tissue damage has been caused, thereby potentially improving ablation therapy outcomes. So my hypothesis, therefore, is that by evaluating and comparing the tissue characteristics post-ablation, we can then differentiate between transient and persisting tissue changes to guide ablation therapy at the time of the procedure for improved patient outcomes. We already obtained promising results that were solely based on the MRI images obtained during the procedure itself, so without post-ablation imaging yet, which I will shortly discuss here. So we performed MR imaging directly pre- and post-ablation in 13 patients with typical atrial flutter using various tissue characterization methods. And these methods included T2-weighted imaging for visualizing edema, quantitative T1 mapping, dynamic perfusion imaging, and late enhancement imaging. When we look at the T1-weighted imaging, they demonstrated edema in the ablated region in all patients with an edema ratio significantly increasing from 1.6 to 3.3, and this is also clearly observed at the yellow arrows in the shown images. I think this is nothing new. I think most of you would expect this result, and we certainly did so too. But when we look at the quantitative T1 mapping results, which has never been performed and follow-up patients after cardiac ablation therapy, there was a clear increase in the T1 relaxation times of the ablated tissue compared to the normal myocardium. Also something that you would expect, because if there is edema, you would of course also find an increase in T1 relaxation times at those areas. But although this increase was thus expected, we found some interesting results when looking into more detail in this increase in T1 values. So when distinguishing the regions that showed no reconnection compared to those that showed acute reconnection at 15 minutes post-ablation, T1 mapping demonstrated a significant difference in the increase in T1 values post-ablation between those regions. So both in absolute values, as shown in the center box plot, but also in percentages, as shown in the box plot on the right. We found that right atrial T1 mapping was also found highly reproducible, with a non-significant bias of only 12 milliseconds. A high correlation coefficient of 0.93 between the two observers was found, with an interclass correlation coefficient of 0.92. Then if we move over to the perfusion imaging and the LG imaging, we found that when analyzing the first pass perfusion images, perfusion defects and regions of LG with a central area of hypoenhancement were found in all patients. So these suggestions suggest that ablation necrosis and previously reported areas of microvascular damage and hemorrhage. So MRI tissue characterization of acute ablation lesions during MRI-guided atrial flutter ablation demonstrates edema, perfusion defects, and necrosis with a core of microvascular damage. Atrial T1 mapping of the acute ablation lesion is feasible and reproducible and may distinguish regions that require acute ablation points. So these are exciting results that again raise the question whether imaging findings during MRI-guided ablation therapy can predict procedural success. And fortunately, with the awarded VENI funding, I hope to be able to address this question in the upcoming years. So finally, I would like to thank all the collaborators of our multidisciplinary ICMR team here in Maastricht for the exciting journey that we already had together and for all the adventures that are yet to come. But first, I will have to head back to Switzerland tomorrow to continue my one-year fellowship at the CHUV in Lausanne. I'm working here on a challenging new project as well that should make MRI more accessible to everyone all over the world, which is low-field MRI at only half Tesla, at only a field of a half Tesla. So thank you all for listening, and I wish you all an inspiring remainder of this beautiful Carim Symposium. Thank you. A bit shorter, but I think I can make up a bit for the time that we lost on the first presentation.
You're doing us a big favor, thank you. Questions? Yes, I see.
Thank you, Rob, for a fantastic presentation. Really clearly explained your research. I was just wondering, with these improved imaging techniques and your expertise in that field, you focus on ablating arrhythmias. As we all know, the substrate increases and becomes very difficult to ablate the longer they exist. So wouldn't it be a logical step to apply these imaging techniques to identify the timing of the ablation? For example, in a screening program, ablating patients who are not really at the end stage disease, but earlier on. Could you detect those substrates?
Yeah, of course, now we first start with only treating arrhythmias in the atria, because I think this is under development or maybe already out, but we don't have it yet, which is like a dedicated 12-lead ECG system. So we are now a bit fixed to the atria. And in the atria, of course, everything is a lot more difficult, but I think T1 mapping has proven to be, at least in this preliminary, at least based on these preliminary results, the T1 mapping is an excellent way of actually detecting these areas. But yeah, of course, you can do an MRI scan beforehand as well to see if there is any substrate in the atria. I mean, this field is, of course, also continuously improving. That would certainly be possible, yeah.
Tilman? Oh, Jordi first.
Sorry. Thank you, a beautiful project, very exciting. My question relates a little bit to what Ellen was asking, is whether you could indeed also foresee that you, of course, as you say, the beauty of the MRI is that you get a lot of information about substrate and that might be there. So I was wondering whether you foresee that indeed in the future you would also use this, for instance, to look at adipose tissue that might be a trigger of the arrhythmias, and integrating kind of these different kind of substrate components to maybe beforehand, but maybe during the procedure, really guide optimal treatment. Yeah,
for sure. These are very interesting fields to look into as well. the easy thing here is normally if you would, of course, we do an increasing amount of imaging before also standard ablating procedures nowadays. But the thing there is you first have to put one in the MRI scanner, patient has to come again, and here the patient is already in there, the patient is intubated, the patient is there completely at a standstill, and it makes imaging so much easier for us, but also it's much more accurate because when you're going to start the ablation therapy, the patient is there exactly as is on the imaging. And this is something new but very exciting.
Rob, very nice presentation. A question, we are looking very much forward to the photon counting CT. And I was actually wondering how much do you think that could offer us also in the future, maybe as an alternative to the MRI, because that's quite cumbersome to be honest. If we could see delayed enhancement with photon counting CT, then we could maybe even perform ablations in the CT room, making it much easier and also getting all the different technologies that are available like RF, cryo, pulse field ablation also to be performed in the same environment. What do you think about that for the future?
That's also a very interesting avenue, I would say. Photon counting definitely has some real improvements over conventional CT, and I think scar imaging may be one of them. I'm really an MRI guy, I have to say, and I think that CT is not on the level yet of performing late enhancement as you do with MRI. But this is just one let's say spectrum of tissue characterization, and I think, for example, T1 mapping, edema, this is all very hard to see on a CT scan. And I think these more easier ablations you can perhaps do on a CT scanner, but if you really need a lot of real-time imaging, I would not suggest doing that in a CT scanner. So, and I have to say, by the way, the results that I just showed here of these 13 patients, I reserved an email from Miranda Bijvoet this morning, so this paper has been accepted in European Heart Journal Cardiovascular Imaging. So, congratulations. Yeah, I forgot to mention that. It said submitted, but it's accepted as of today.
Oh, that's great.
Congratulations.
It's another paper for the sheet.
Yeah. Well, the current imaging technique enables you to differentiate between stable and transient tissue damage, and maybe also be a decision maker for re-ablation. Will it also help you to adjust the procedure maybe on a intensity basis to steer towards more stable tissue damage? Can you do that, or is that not possible?
Yeah, the whole idea is that what we do now is, I'm not a electrophysiologist, but what is happening there is of course, you perform this ablation therapy, you wait, let's say 10-15 minutes, and then you're going to do your testing and see if you have an electrical block. Right. But sometimes this electrical block is just temporarily there and just heals over time, and the arrhythmia comes back. So we really want to know are these tissue changes? I mean, we don't know that at the time of the procedure now, but by looking at the follow-up imaging in these patients, we can correlate back and see, hey, could we already check at the time of the therapy if this change that we created there by the therapy, if that will be transient or persistent? And this is the whole thing. We want to know at the procedure if we perform persistent tissue damage.
Okay, and then answers yes.
That will be a major breakthrough. Okay, one more question?
Yes.
Does it work? Yeah, it works. Well, excellent presentation. One question I have is, how do you see the clinical implementation of this? Because well, with an MRI, if you're looking to perform these interventions with an MRI machine and then also possibly reperfusion, re-ablation where necessary, the clinical availability of MRI is a lot lower than CT and other modalities. So do you think that would in any way be an obstacle?
Yeah, that's a good question. To be honest, just to give you some information, these atrial flutter ablations that we currently do have, I think, a success rate of 98% with conventional therapy. But therefore, MRI will never ever replace conventional ablation therapy for these patients. But I think if you move towards the more complex ablations, for example, in the ventricles, like really complex VT ablations, I think that is the real field where I think that MRI ablation therapy has a real advantage, because nowadays these Treatments cost quite a lot of time. We only make them longer because we want more imaging. But yeah, the ablation therapy is basically the same. It's just because we do so much imaging before and after that the whole procedure takes longer. So for these atrial patients, I don't really see, at least for these atrial flutter ablations, I don't see a real benefit yet, but this is just a step to work ourselves up towards the more complex ablation therapy treatments, and I think that is where MRI is really going to make the difference.
Yeah, then one quick follow-up question. Because you also look at tissue characterization, so T1 and T2 relaxation times through T1 and T2 mapping, but those are field strength dependent. So is there also a plan to validate these interventions in terms of field strength?
Nowadays, these catheters and the whole equipment has only been released for 1.5 Tesla.
Ah, okay.
So we can go lower, but definitely not higher, but we don't have that system yet, so we are good for now.
Maybe in the future.
Who knows?
Well, thanks so much for this wonderful discussion, and with that, thank you again, Rob. The next speaker is Judith Koosmans, who will tell us a lot about the CardioSite project that I'm also actually involved in. So to me, the topic is quite familiar. Looking forward.
Thanks, Blanche, for the introduction. I would also like to thank the organization for giving us the opportunity to talk about our CardioSite project. So this is a project that's funded by through 3 different heart foundations from the Netherlands, Germany, and the UK. So the disease of interest in the project is heart failure with preserved ejection fraction, and this is a form of heart failure that is characterized by stiff and thick chambers of the heart. That makes that the heart is not able to fill properly with blood. In the project, we hypothesized that platelets play an important role in the pathophysiology of HFpEF. First, a bit more about HFpEF and its pathophysiology. It's known that in the comorbidities that are associated with HFpEF, that's type 2 diabetes, obesity, hypertension, that there is systemic inflammation in these comorbidities, resulting in a microvascular dysfunction. And we see that in multiple organs. In our own project, we are interested in the heart. And we see that this microvascular dysfunction manifests in multiple ways. On a molecular level, we see that there is enhanced leukocyte adhesion to the endothelium and also enhanced infiltration into the underlying vascular tissue. We also see upregulation of specific adhesion molecules on the endothelium, and this results in a pro-inflammatory but also pro-fibrotic phenotype. This results in a loss of capillaries in the heart, and also in that the arterioles are not able to regulate vascular tone normally anymore. So in the field, there is really, the HFpEF field, not a lot known about platelets, and we think they are an overlooked player in the pathophysiology of HFpEF. Because we do know actually quite a lot of platelets, on platelet pathophysiology in the comorbidities, and also on the role of platelets in vascular inflammation. In particularly from mouse studies, we know that platelets can promote vascular inflammation, and are actually 2 main mechanisms via which platelets can do that. So we know that platelets can facilitate leukocyte recruitment and transmigration, and you just saw on the previous slide that that is an important aspect in microvascular dysfunction. And platelet chemokines are an important player herein. And secondly, there is extensive transfer of information from platelets to the endothelium and from the endothelium to platelets. And in the CardioSite project, we are particularly interested in the role of microRNA transfer from platelets to the endothelium. So this is how platelets can promote inflammation. It's also known that inflammation can alter platelet activation and platelet production. This is a recent study from our German partner in the CardioSite project, Tobias Petzold, and he actually elucidated part of the mechanism via which inflammation can alter platelet production. And what he has observed in a mouse model of myocardial infarction is that neutrophils home to the bone marrow and directly interact with megakaryocytes, which are the mother cells of platelets. And this interaction of the neutrophil with the megakaryocyte alters platelet production, so we see more platelets being generated and also a more reactive platelet phenotype being generated. So these data combined with pilot data that we have gathered by our teams led to the hypothesis of the project, which is depicted here. So we believe that the systemic inflammation seen in HFpEF leads to an altered platelet production and also to a different type of platelets being produced. We believe that these platelets can promote the vascular inflammation in the microvasculature that you see in HFpEF, and you get this kind of vicious cycle of inflammation leading to more inflammation and more damage to the microvasculature. In the project, we hope to prove or disprove this hypothesis, and we aim to break this vicious cycle, and specifically we want to do that by interacting in the communication between platelets with the endothelium and neutrophils. This is the team involved in the project. So our partner from the United Kingdom is Mary Britton and her team from the University of Edinburgh. Mary is an expert on endothelial cell biology and heart failure, and she has unique mouse models to look at the formation of new blood vessels and advanced omics techniques. The group of Tobias Petzold in Germany will investigate platelet production in mouse models of HFpEF, and particularly investigating the interactions of neutrophils with megakaryocytes. And we in Maastricht, so that's me, Blanche Groen, and Rory Koene, we will make use of the really advanced and well-phenotyped HFpEF patient cohort that is available in Maastricht, and we will do studies looking into platelet biology and non-coding RNAs. So we aim to elucidate the role of platelets in the pathophysiology of HFpEF, and thereby to identify and develop new therapeutic strategies with aim to enhance angiogenesis for the treatment of heart failure. So the project has just started. I would like to show some of the data that we have obtained in leading up to the project. And I will show a few slides on the data that we obtained with the patient cohort in Maastricht. As I just mentioned, the HFpEF cohort in Maastricht is really well characterized and phenotyped. This is the team involved in the studies. So on the top row are clinical partners, and the bottom row are the laboratory experts. So far, we have included a bit over 100 individuals with HFpEF and 40 controls, and we choose to include matched controls, meaning that they are matched on as many characteristics as possible, but they do not have HFpEF. So differences between the groups is that there are more individuals with atrial fibrillation in the HFpEF group compared to the controls, hence also more anticoagulant users, and of course we see more medication linked to heart failure in the HFpEF group. So we have obtained blood samples, and with these blood samples we have performed several studies. So in the plasma we've looked at markers reflecting platelet activation, endothelial neutrophil activation, but also we've dived into the blood coagulation. With platelets and whole blood, we perform platelet activation measurements, and also RNA is collected for RNA sequencing. So we've just sent off the samples for RNA sequencing. We are waiting the results, so that is something I cannot show, but I will show a few slides on the plasma measurements and the platelet activation measurements. So we measured several markers reflecting platelet activation and coagulation, and I summarized them in the table and shown on the right part as an example of a platelet marker, which is beta thromboglobulin. And actually what we saw is that there was no difference between the matched control group and the HFpEF group. And that was similar for coagulation markers, in this case shown for the thrombin, antithrombin complex. So based on these plasma markers, we cannot really discriminate between the controls and HFpEF. What we did find is that actually in both groups there is enhanced platelet activation and coagulation compared to the reference values, which is values of healthy controls. So with regard to platelet studies, I only want to show the data that we have obtained with our Maastricht flow chamber, which is one of the hallmark techniques in our laboratory. So with this technique, we can look at thrombus formation, so blood clot formation, in real time under a microscope. And we have all types of analysis to discriminate different platelet activation markers and to look at the morphology of the thrombi. So these are the typical movies that we then make. And if we then look at some representative pictures of the match controls and the HFpEF patients, I think even a non-trained eye can see some differences between the different pictures. For me, what was a striking finding is that in the controls on the left, you can see these kind of strands, these fibers sticking out of the blood clots, and these are actually fibrin fibers. And we do see them with the control blood samples, but not in the blood from the HFpEF patients. We excluded anticoagulant users for both groups. For me, this indicates that the clots from the blood from the control groups are more reactive than from the HFpEF patients. And that is something that was also proven in the analysis that we performed. So we see that these thrombi from HFpEF patients are smaller in height and also less able to contract, and that they have a lower amount of fibrin-fibrinogen binding. So we've done additional experiments on a non-coagulating condition. Confirming this, we've also done studies with isolated platelets. And also here we see that the platelets from HFpEF patients are dysfunctional, meaning that they are less, you can activate them less well. So last but not least, we also looked at neutrophil activation, and this has been demonstrated in HFpEF that there is enhanced neutrophil activation. That's something we found also in our cohort. We do not know what this means for platelet production, and that is something we want to find out in the MegaCardioSite project. So with that, I already come to the conclusions. So we know that HFpEF is associated with microvascular alterations of the heart. And in our own Maastricht HFpEF cohort, we have found that there is elevated systemic activation of platelets, coagulation, and neutrophils. And we see that platelets are dysfunctional in the HFpEF group. So we're really eager to dive further into the underlying mechanisms involving platelet generation and platelet endothelial interactions in HFpEF. So these are, it's a team involved in this project, and I would also like to thank Carim, because we were awarded a PhD call in 2020, and it was actually quite important for us to gain a substantial amount of pilot data and to appoint Georgia, our PhD student, who's been instrumental for us to apply for the grant. Thanks for your attention.
Thanks so much, Judith. Questions from the audience? Yeah, Harry.
Thank you. Very nice story. And in the beginning, you said that your overall purpose of this project is to develop perhaps new strategies for angiogenesis to enhance the microvasculature in the heart.
Yep.
Now, one of the drugs that oncologists are very fond of nowadays are anti-angiogenic drugs to reduce the tumor prognosis. And in the list of medicines that you mentioned, where you compare your control groups and the HFpEF groups, you indicated a number of cardiovascular drugs influencing thrombosis and influencing cardiac function, but you did not make any mention of the use of anti-angiogenic drugs, which are known to cause heart failure. in the long term when they are used too much. So could you correct your group, your control group, and the HFpEF group for that particular item of drug use?
Yeah, for sure. I think those data are available, so that's for sure something we can do. And I actually have not looked at it from that perspective, so thanks for the suggestion. It's definitely something that we will pick up.
Okay.
Yeah.
Yeah.
Paul Shiels here in the front.
Hi. So I enjoyed that. I learned a lot, and it just struck me that I didn't understand how your observations would be affected potentially by microbial metabolites such as phenylallyl-glutamine that have been implicated in heart failure. Have you thought about that or looked at it?
I'm not sure that I understand the question. I'm sorry.
So when you showed up some slides, you were comparing controls with HFpEF.
Yes.
And you were looking at the platelet aggregation, activation.
Yeah. Yeah.
How do you think that would be affected by different levels of circulating microbial metabolites, such as PAGN?
Influenced by different levels of circulating, and then
microbial metabolites.
Microbial metabolites.
So, yeah, phenylacetylglutamine in particular.
I have no idea, to be honest. No. No, so maybe we can discuss that afterwards, because I'm interested to hear your considerations about this question. Yeah.
I thought the circulating levels of PAG were used to stratify potential outcomes in heart failure patients.
I don't know.
So that is a great topic for further discussion, and I know that's your main interest. That's the microbial products. So that's something that we are. Well, I'm also involved. That we are actually not onto at this moment, but certainly a great opportunity.
May I?
Yeah.
Still time. Hi, Judith. Very nice presentation. Do you think that the platelet reactivity is cause or consequence in the HFpEF?
I think it could be both, because we see it goes in both ways. So we see that the inflammation causes platelets to be more reactive, and then the more reactive platelets, we think, enhance the vascular inflammation. So we think, maybe it's a chicken or egg question. I think it's both.
So you think that if you intervene in the platelet reactivity, for example, that you stop this vicious cycle of...
Yeah, we think, at least in the project, we want to interfere with the communication between platelets and the endothelium, either directly via interfering specifically with microRNAs or via interfering with the crosstalk with neutrophils, because we think they are a very important player in the vascular inflammation, but also in the platelet production. So I think that it's... Yeah, we're interested to interfere in the communication, because you do not want to hamper with important functions, physiological functions of platelets.
Thanks.
There are more questions. Fritz?
Thank you, Judith. Great work. I was just wondering about the definition of your control group.
Yeah.
And I may have missed it. I mean, are they, say, just age and sex match individual without a disease, or other kind of heart failure?
Yeah, the control groups are individuals that presented themselves to the cardiology department with complaints of chest pain, and they have several investigations, and they did not turn out to have any obvious signs like myocardial infarction. They also do not have heart failure. But they do have, many of them have hypertension, some of them have atrial fibrillation, so they are not healthy elderly. They are elderly with several comorbidities, and we deliberately choose for this group to have a group that has many similarities to the HFpEF, but does not have heart failure, not HFpEF, but also not have REF. And it's always an interesting debate, which control group do you choose? So for the mega CardioSite project, we will also include healthy controls.
Yeah. And does it make, you mentioned HFrEF, does it make sense to add a group of HFrEF patients in that matter?
Well, actually, some of the individuals that were thought to have HFpEF at first turned out to have HFrEF, and we have already included them in our study, so we have a small subgroup of HFrEF, and we might expand that as well.
Ellen?
Well, great presentation, and just kind of a follow-up question to Fritz's remark. In the clinical setting, we are focused on cutoff values. For example, patients with symptoms, then we say it's heart failure, and without symptoms, it's not.
Yeah.
Something that might also help you with your control group, wouldn't it be an idea to use diastolic dysfunction, for example, as a continuous variable, instead of using a cutoff value which is used in the clinical setting? Because in this study, you have a chance to redefine these issues.
I think it's an important remark. We choose for the to have a clear cutoff. I think that's important for our study, and at the same time we have all the clinical values. So what we would like to do is to do advanced statistics to see which parameters correlate with which clinical parameters. And I think that's a particular strength of the Maastricht HFpEF cohort, that there are so many clinical or subclinical parameters collected that really enables us to do that. And so we have the continuous values.
Okay, there's one more question at the back.
In the beginning of the presentation, you mentioned that you were looking for therapeutic targets. But if we look, on a bit of a wider scale, you also mentioned that two of the main problems with people with HFpEF are hypertrophy and cardiac fibrosis. In what way would this treatment affect that? Would it even have like a therapeutic effect on both of those parameters? And if not, wouldn't it be better to apply this treatment to people who are asymptomatic and in a pre-heart failure stage?
Yeah, so that's a good remark. So your question is, maybe it's too late for the targets we want to identify, and should we not apply that to a group who is prone to develop heart failure? That's actually also one of our goals. So we're also interested to look at patients with INOCA, because we also see that they have microvascular dysfunction and that they are prone to develop HFpEF. So I think in the end, the idea would be to intervene at an earlier time point. So this is a very basic science project. So we aim to find new targets, and we think there are of potential use in HFpEF, and to what extent they can make a difference, that is at this stage, I think, far from what we can obtain in the project. But we indeed aim to also apply it to groups who are prone for developing heart failure.
All right, thank you.
Okay, with view of the time, thank you so much, Judith, and thanks all the speakers for this wonderful session. We will have a break now, and we will come. Yeah. Yes. Joachim.
Okay.
Oh, there have been keys that were found, and they are with Joachim in the back. So someone who lost their keys, his or her keys. Thank you so much, all the speakers, and we'll be back at 11:30.
While everyone finds their seats back, it's my great pleasure to welcome you all to the second session of today's Carim Symposium, which will have 3 exciting presentations related to the Topsector plan, medical and health sciences. Looking forward to this, 3 different topics that we will discuss. And the first presentation will be given by Astrid Hermans. It will be on the optimization of personalized and integrated remote atrial fibrillation care to reduce socioeconomic disparities. Astrid.
Thank you for the introduction and for giving me the opportunity to present our top sector plan prevention on this Carim Symposium. And it's titled The Optimization of Personalized and Integrated Remote AF Care to Reduce Socioeconomic Disparities. Atrial fibrillation is the most common sustained atrial arrhythmia and is characterized by an irregular and often very rapid heart rhythm. In the Netherlands, AF is affecting approximately 350,000 people, with around 31,000 newly diagnosed AF patients per year. AF patients often experience a reduced quality of life and shorter life expectancy, and in the long term, AF can contribute to the development of heart failure and stroke. In addition, AF may lead to increased hospitalizations and associated healthcare costs, and the AF incidence is higher with worse socioeconomic position. In particular, patients with AF experience more often comorbidities in AF, especially patients in Limburg. And several studies have shown that those patients with low socioeconomic position and more comorbidities in AF have more often poor access to healthcare. There are several socioeconomic determinants that have an important influence on this limited healthcare availability. Such as financial resources, a decrease in social support, decreased language proficiency and health literacy, but also an increased distance to the hospital. Partly based on this, the mission of the Dutch government for the next upcoming years is that in 2040, all Dutch people will live at least 5 years longer in good health, and health disparities between the lowest and high socioeconomic groups have decreased by 30%. Early remote AF detection and management may offset most of these before mentioned socioeconomic obstacles. And to achieve this, traditional face-to-face outpatient AF consultations should be transferred into teleconsultations using mHealth. The last couple of years, many mHealth solutions have been introduced to assist in the detection and the management of AF. And these mHealth solutions differ in diagnostic accuracy, and the diagnostic accuracy can differ with respect to the technology used, as you can see in this figure. ECG documentation, many mHealth solutions use ECG documentation, but others base their heart rate and rhythm assessment on PPG. PPG technology is an optical technique that detects blood pulse variation in the microvascular tissue of the fingertip by measuring reflected light by the built-in camera of a smartphone. And the differences in technologies may have important implications. ECG technology is necessary for the diagnosis of AF, and although PPG technology cannot be used to diagnose AF, it has a high accuracy to detect AF in both symptomatic and asymptomatic patients that are already diagnosed with AF. The accuracy depends not only on the technology used, but it's also dependent on the way of data collection. Think of spot versus longitudinal assessment. On the method of measurement, we have handheld devices and wearable devices, but also it depends on the placement on the body and the number of leads used. Although mHealth solutions are becoming increasingly popular in the detection and management of AF, there are several barriers to widespread the adaptation of mHealth in healthcare systems. One of the challenges is the accessibility to enable a smooth flow of information between patients and physicians. A shared infrastructure, and in most cases an online cloud, is necessary to make patient data remotely available. Other mHealth solutions lack of scientific validation, and others are written at high reading grade levels, which could be challenging for patients with limited health literacy. Health data from patients using mHealth devices are exchanged via wireless networks, and thus addressing the privacy and security concerns is also necessary for the use of mHealth. And in addition, a physician-initiated or at least guided approach is necessary to personalize treatment of mHealth use and for the right selection of an mHealth tool for each patient. And last but not least, data overload is also a barrier for healthcare professionals adapting mHealth technologies. An mHealth project that took into account most of the before mentioned challenges is Telecheck AF. Telecheck AF is an on-demand mHealth infrastructure which we developed during COVID-19 to support teleconsultations in AF patients. And Telecheck AF incorporates three important components. The first one is a structured teleconsultation. The second one is an on-demand app-based heart rate and rhythm monitoring infrastructure. And the third one is comprehensive AF management. And the mHealth-based infrastructure is based on an CE-marked mobile app using PPG technology to measure heart rate and rhythm monitoring semi-continuously prior to a teleconsultation. Patients were instructed to use the mobile app 3 times daily and in case of symptoms for 7 consecutive days. And an mHealth prescription was activated to connect the patient's app with a secured cloud. And currently, 41 European centers are implemented in this Telecheck AF approach. Within the Telecheck AF approach, we also looked already into several subjects. For example, we evaluated the experiences of participating centers and recruited patients. And as you can see here in this figure, the centers felt comfortable to interpret PPG recordings. They agreed that heart rate and rhythm monitoring assessment using an online cloud was trouble-free, and that they can use the heart rate and rhythm monitoring assessment during teleconsultation for medical decision-making. And in addition, that the onboarding process was simple. Also, the patient experiences were very positive, and 2 examples are that the patients would like to use the FibriCheck app in the future, and many patients agreed that the FibriCheck app was easy to use. Then we looked into the age distribution of our Telecheck AF users. And as you can see in this figure, more than 60% of the patients was older than 60 years. And even patients older than 80 years were able to use the heart rate and rhythm monitoring application. And our oldest user was 92 years old. Further, we evaluated already the patient motivation and adherence to use the heart rate and rhythm monitoring application. And we found that 1/4 of the patients had both optimal motivation and adherence, which is an optimal motivation and adherence are defined as at least 100%. The red circles here in this figure indicate patients older than 68 years old. And therefore, this figure demonstrates that elder patients have more often an optimal motivation and adherence compared to the rest of the population. And therefore, healthcare professionals involved in the management of AF patients should not be discouraged to provide an mHealth infrastructure to elderly patients. And finally, we looked into the changes in healthcare utilization and declarable care products during the implementation of TeleCheck AF. And as you can see in this figure, within the TeleCheck AF approach, the number of teleconsultations increased by 45%, and the number of face-to-face consultations, ECGs, but also the Holter and echocardiograms dropped significantly. In addition, we saw that there was a downward shift in declarable care products in 57% of the patients during TeleCheck AF. And these results are created a basis for a new reimbursement code for TeleCheck AF in the Netherlands. And this is also launched on the website of the Dutch Health Authority. Despite all these positive results of TeleCheck AF, optimization of the TeleCheck AF infrastructure is necessary to make integrated AF care feasible. And in addition to the TeleCheck AF infrastructure based on heart rate and rhythm monitoring, the comprehensive version of the TeleCheck AF infrastructure will focus on cardiovascular risk management, but also on lifestyle coaching, patient education, self-management, medication management, and rehabilitation. And we are currently here in Maastricht busy with the building up this this infrastructure. This comprehensive TeleCheck AF infrastructure may lead to increased access to healthcare and can contribute to a better realization of the right care of the patient and place, and may also increase patient outcomes and experiences, resulting in better personalized, multidisciplinary, integrated, effective, and the right AF care together with the patient at the right place and time. And consequently, this will may lead to an increased reduction of socioeconomic disparities in the management of AF patients. To strengthen the integrated AF care, it's also important to focus more on remote AF care development. And therefore, here in Maastricht, we are developing an online platform for physician and patient, and this online platform will make the interaction between physician and patients remotely more feasible. Via the platform, mHealth applications can be linked and are transparent in a dashboard. And in this way, mHealth solutions do not require separate online clouds anymore. And patients can use only one application to measure all the different variables important in AF patients. The online platform will serve as a storage location for self-monitoring data, and dynamic changes over time will be summarized in a dashboard. The dashboard for the patient will be personalized based on age, education, but also on socioeconomic status, and will include personalized planned care to ensure personalized and integrated AF care at a distance. So in conclusion, to strengthen our integrated remote AF care, here in Maastricht, we will focus on the optimization of the telecheck AF infrastructure, and will focus on the development of an online platform for physician and patient. To contribute, which may lead to the reduction of socioeconomic disparities in the management of AF, and this is aligning with the mission of the Dutch government. Thank you.
Thank you very much, Astrid. And indeed, I think Maastricht has really pioneered this topic and ultimately resulting in the reimbursement of this approach, which I think is a great, great result. Any questions from the audience? Let's see if I can hold my own mic and throw this one. It's an extra challenge. There we go.
Thank you so much for your excellent presentation. I was just wondering, how are you searching for your patients that have a low health literacy to identify whether they use the telecheck? Because it's quite difficult to identify those patients. So I was wondering, how did you incorporate that within your study?
We include patients that are already here in the hospital. So we include all patients with AF, so also the patients with socioeconomic, a low socioeconomic status. But I think we will use questionnaires to see which patients are really those with a low socioeconomic position compared to the other ones. And based on this, we will make a difference between the patients.
And will you look at differences in health literacy as well then?
Yeah.
Because not every low health literacy patient has a low socioeconomic status. It could also be...
Exactly, but we will use in our mHealth device a level of health literacy that is good also for the low socioeconomic patients, so that we took that into account as well.
Great, I will talk to you later about that, how you identify.
We have several follow-up questions. Short questions will go to our guest of honor first, and then...
Thank you. This is really interesting. As a person who still uses telehealth in my practice, it's just great to hear this. So you showed us data on the adherence and motivation of the participants, and you showed the relationship with age, but did the adherence and motivation differ by socioeconomic status? Because that's what you're hoping to...
Yeah, that's a good question. We didn't look into that yet, but it's good to see if there are indeed differences in motivation and adherence between low and high socioeconomic groups. Yeah, thank you.
I'll take a final question and short answer. Yeah.
Hi, just a short question, if you will, but that is it morally okay to interact with people differently based on their socioeconomic status? Is this something which you guys have discussed with, let's say, ethicists about?
No, we didn't really discuss that, but we want to involve every patient in the same way in those studies, and we only make a difference in to see how they react on mobile applications, but we will took them into account at the same way as other ones.
But you said the app will look different for people based on socioeconomic background, or did I misunderstand that?
Yeah, it's only based on, for example, more videos or a little bit more instruction, but indeed maybe we have to discuss it with the ethical committee if it's okay to do that in that way.
Very good. Thank you very much, Astrid. We will continue with the second presentation given by Yannick Nielsen, who will talk about the Maastricht medication data link. This one,
Thank you very much for the introduction, and thanks to the organizing committee for letting me give me the opportunity to present our project here today. My name is Yannick Nielsen. I'm a hospital pharmacist here at the local hospital, and in the past few years I've been working on mostly pharmacoepidemiological research. And Just to give you an idea, generally we look at some kind of exposure to a drug, and then we're interested in whether that drug has some kind of outcome, or whether it benefits the patient in case of in its effectiveness of the drug, or maybe side effects, but it could also be patient-reported outcomes that we collect. And we usually use large databases from, for instance, from the UK primary care setting, or from Denmark. But like we've seen earlier this morning, drug use is not only interesting in studies that look at exposure as a primary question, but could also be interesting if you look at other kinds of interventions, such as surgery, like we've seen this morning. And usually then there might still be some effects of the drug in the association that that researchers might be interested in. So I think drug use is a factor that's important not just for the pharmacists, but for all kinds of medical research that we do within Carim. And if we look at how drug use is assessed or is collected, then often we use cross-sectional data, using questionnaires, asking patients to bring their medications to the research center or to the visit at the hospital. And as I've depicted here, there might be some disadvantages depending on the research question that you have using this method. Other things that we see is that we collect longitudinal data from public pharmacies, and particularly here, we might have some issues concerning privacy and the cooperation of other stakeholders, and often it's very time-consuming to collect all these data. So if we just look at our hospital and just by counting the windows, you can imagine that there's hundreds of patients in this building that on a routine daily practice get prescribed drugs every day, and currently that data is just not being used. So just to give you some preliminary numbers on the data that we've collected with the current prescribing system that we have, it started in 2005, and it's going to be used until November of next year. And up until now, we see that we have over 280,000 different patient IDs in that system, with over 7.5 million individual rows of prescriptions. And just a rough estimate is that we actually see about 1,000 new prescriptions every day. So a massive amount of data that's being produced in routine care. As a researcher, we don't have to put any effort into it, and it's just sitting there waiting to be used. So the aim of our project is to get this data moving. Well, I've written it down here. So we want to create a data set that includes all electronically prescribed hospitals prescriptions, or prescriptions that were continued while patients were at the hospital, so that we can use it in a wide range of studies, and especially make it linkable to other kinds of data sources that we have locally or regionally or nationally or internationally. So the project started a couple of weeks ago, and it's going to take 2 years until September of 2025. And to just give you an overview of how we are going to fill those 2 years, so we probably will extract the first data in the following weeks. It will probably be data up until the beginning of this year. And that's when the majority of the work will take place in the following months, where we'll clean and validate the data so it's usable for research and maybe also in our clinical practice, of course. Then we'll have a final data extraction at the end of next year, because that's when the hospital will switch to a new prescribing system, and that way we'll have the end of our static data set with the current system. We also want to write some standard operating procedures for researchers like you. If you want to use the data, that you know how to use it properly for the typical research questions that you would have. Well, and then we'll have to clean that final data set, and we'll do some studies ourselves looking at whether we have population that we would expect to see in a hospital like ours, and look at specific populations and see what kind of drug utilization we'd have in our data set. And just to give you a preview of what the current data set would look like. So this is an example. This is fictional. These patients do not exist. But just to give you an example, that we have multiple patients, and every patient has, for each prescription, will have a separate row with a start and an end date. And we'll have different variables available. So this is just a small example. There'll probably be a bit more. And all those variable names we will rename to the nomenclature that's used in the ZIPs, the Zorginformatiebouwstenen. So that will make it linkable to other cohorts or data sets that use the same kind of data structure. And just to give you an example, so in this case we have 3 patients, and if you look at the first patient, we have 2 drugs that are being used, and if we zoom in on the first one, you can see that we have a start and an end date for several prescriptions over a course of a few months, and at some point you see that the dose has changed. So that way we can follow up longitudinally what the drug use within a specific patient would be. Other things to take into account, because this is a hospital data set, people don't stay in the hospital all the time. So we could also have significant gaps in our registration, so that's something to keep in mind when using a hospital-based data set like this. Might be free text in there as well, so we have to think about how can we use this and how can we use technologies to extract data from these kinds of data formats as well. And something else we have to think about is that doctors also make errors sometimes. So for instance, in this case, instead of prescribing 600 milligrams, the doctor prescribed 600 pills. So we have to think about how do we deal with these kind of errors that are going to be in the data set. Yeah, so that's something we'll be working on in the next few months. And just thinking about the opportunities that we would have with this data. So if we have just the Maastricht medication data link, like I said, we can do some studies on drug utilization, maybe something on prescribing cascades. And even if we only have drug data, you can use drug as a proxy for some kind of a disease. For instance, if you're interested in infections, you can use of antibiotics as a proxy for your outcome, and you can do some drug exposure to outcome studies as well. But when it really becomes interesting, if you can start linking it with other data that we collect in the hospital. So one of our next speakers is going to be from the intensive care unit. It would be interesting to be able to link with that data. They use a different system, so the medication data, to get more continuous medication data would be interesting to see how we can link that. Well, there's a lot of other things that we collect in our hospital as well that's worth linking. And the next step, of course, would be trying to link it with external data. So with your research projects, your cohorts, I think we've seen a project earlier this morning using medication data. Instead of asking the patient, doing those questionnaires, it would be great if we could link it to a data set like this. And my personal interest would be trying to link it to outpatient and public pharmacy data as well. So we're just at the beginning. It's going to be, this project is going to be on just the hospital medication data, so it's a start. We have to start somewhere. Especially with the switch to the new system coming up at the end of next year, we don't want to lose the very valuable data that we have now. So it's a great time to start collecting this and making it available for researchers. And hopefully in the future we'll be able to grow and to link it to other study cohorts that you're working on. So that brings me to the current status. Well, for me today, I'm very interested to see what your thoughts would be. I would like to receive input from you. What would you like to see in a data set like this? What would you like to use it for? I'm very happy to talk to you about that today. I'll be here all day, and if not, you can contact me on that email address. And with that, I would like to thank you for your attention.
Thank you, Yannick. Very interesting and ambitious project, I think. So, but very important. As you say, we need to make use of the data now that are here, and this is a first step, but certainly not the final step in getting there. We have questions from the audience. I don't have the... There it is. Yeah.
Thank you very much. Yeah, large potential, I would say, this data set. I have two small questions. So what you are registering is that only medication prescribed in the hospital for the specific treatment what patients are in for, and not for what were they already taken by their primary physician? That's one question. And the other is there is an interesting project by Ben Janssen who analyzed the sewer samples from the sewer from the hospital to look for which traces of medicine are in there. Are these going to be connected, perhaps, these databases?
I guess just starting with the final question, I guess we could, because just with knowing what kind of medication is being used in our hospital, you could definitely see patterns of drug use, and if that would be linked to data from what we measure in the sewers, yeah, it would be great if we could link that. And yes, indeed, so within the system that we have now, it's just going to be data that medications that are either initiated at the hospital or continue during hospital admission. So if people stop the drug at the moment they enter the hospital and then start using it again when they get back home, then we will not capture them in this data set. Yeah.
Thanks for this very nice initiative, and I think very valuable data. I was wondering, because based on your overview, it's actually like the list of prescriptions, but are you also going to link that to the clinical data, imaging modalities, but also the clinical indications for which those drugs were prescribed, or is it only being to be clustered by drug?
Yeah, so at the first stage, it's going to be just by drug. So it could be that I've made a clustering like this, but it's going to be depending on the way you sort it. Of course, it could be either sorted by date or by drug. Or, at some point we will be. That's what I would hope, that we can link it to other data about that. Well, that give us information about diagnosis. So that might be that's definitely recorded in the hospital, because that's the way hospitals claim their insurance. Well, claim their from their healthcare insurances, the healthcare that they provide. But the focus for me now is going to be just getting that medication data available, and in the future, hopefully, with use of other initiatives that we have about sharing and linking data, that would definitely be possible. Yeah.
Nice, thank you.
Helen, we have a question here at the front. Yeah.
Thank you for this really fantastic initiative. And I was just wondering, as you know, patients are becoming older with a lot of comorbidities and polypharmacy, drug interactions, progression of disease. You might have a lot of confounders that might will affect your results and the effect of the medication. Do you consider using, for example, artificial intelligence or those type of advanced ways of looking at data to filter out these effects that you're looking for?
Yeah, that's, I think, a very good question. We're trying to learn more about it. Although we do see that there's some difficulties, but mainly just a lack of experience. But I think there's a lot of potential if you have these large amounts of data to look at prediction models using artificial intelligence to see, especially if you can link it to outcomes, if you can link it to laboratory data, to diagnoses or whatever it's collected. Yeah, you can. The possibilities are almost endless, I would say. Yeah.
Yeah, I think exactly, Yannick. Thank you very much, because that complexity, I mean, that's the thing. All the patients in the hospital get prescribed many, many drugs on a daily basis for different reasons, and the complexity of the effects of each of those drugs, you know, that is really, I think, a challenge where there's probably a lot of room for optimization. And, you know, as you've shown, I think getting the data is step one, and then we can take it further.
We have to get the data.
So we really need to invite you back in a couple of years to see how that comes out. Thank you very much. We will continue with the final presentation of today's session, Frank van Rosmalen, on Table 0, documenting the steps to go from clinical database to research dataset. Frank.
Good afternoon. My name is Frank. I am a technical physician at the Department of Intensive Care Medicine in Maastricht. And I'm also going to talk about data. So I was also awarded the Topsector Plan Medical and Health Sciences, and I would first like to start with the goal. Yannick already told a little bit about it, but the goal is to prepare a clinical source data for use in scientific projects. We have an added goal. We like to document the steps to go from a clinical database to a research data set. And how we plan to do this is like this. These are the steps. First, just like the previous speaker, we have a clinical source database. And this database is optimized to use in the clinic. It means that it's optimized for speed, and it's a system that is bought by a specific vendor, and all vendors have a specific type of storing their data. It is not easily accessible, so the first thing that we have to do is to create a table with which we can work. That means pulling data from different tables within the system and combining them in such a way that we know what we are looking at. This is the initial extraction. Then we have to apply some sort of inclusion and exclusion rules. And then we arrive at what we call Table 0. I was just told that Table 0 is also an R package, but this has nothing to do with the R package. So from Table 0 represents all the people in your data set that have data that you can do something with. And from that, you can select your study population, and then you have the more commonly named Table 1. Why is this important? I am probably not telling anyone in this room something new, but I would still like to say that machine learning, AI, everything with big data is popular over the last years. And what the papers published now usually look like is something like this. There is data, it gets put into a machine learning model, and there is an outcome. The outcome is usually some sort of new insight into something that we want to look at. And only in a very few cases it is something that we can use at the bedside. A less common publication topic is the actual data. So how do we get from a patient to data? And an even less common topic is the actual person itself. And I'm going to explain what I mean by that. So most this type of research always starts with a database. And this is my visual representation of an ICU database. But if this was your database, research would be very easy because all of these patients are the same. So this is a more representative representation of the database. And this is what everybody starts with. And the first step, as you all know, is to create your Table 1. I copied some captions of Tables 1, I don't know. And these are all from studies that have used the same large database as a source. And this is the MIMIC3 database. You might not be aware of it, but the MIMIC3 database is one of the largest ICU databases from America. And therefore, there are a lot of published papers on this topic. And as you can see, it's all baseline characteristics, characteristics of patients, clinical characteristics. So this means that we are now here, table 1. And so you start actually at the bottom of this scheme, which is no problem as long as somewhere you have described table 0. And especially what steps have been made to go from your pre-table to include and exclude people to go into table 0. I did this, or I tried to do this for the mimic table. So I tried to find out how did these people get into this database. And there are 3 things that are stated, and only these 3. 1, all patients admitted to an ICU or emergency department between a certain time period. 2, importantly, data cleaning steps were not performed to ensure the data reflects a real-world clinical data set. Well, that is a choice. And 3, patient identifiers were replaced using random ciphers. So this is a de-identified data set. So what this means is that there are mistakes in the data set, and you are never able to understand them or get them back because the data is de-identified. That made us think what would happen to our own ICU database if we apply these principles, and if we don't apply these principles. Would there be a big difference? So this is what we did in the first step for this project. This is very small, but I will read it to you. In the beginning, we just pulled everything from our database, like everything that is in the database, and then we end up with 54,000 something admissions of 38 something thousand patients. We excluded people outside of the data range. We saw that there were invalid patient numbers, which usually means that these are test patients or patients where something went wrong and they had to be removed from the system. Non-ICU patients were removed. Then we extracted all the patients that did not have a single recorded heart rate, because that is strange if you are on an ICU. We excluded patients under 18 and patients who were not in our National Intensive Care Registry, because you should be in there if you were an ICU patient in the ICU. And last, from the people who were not registered in the ICU registry, we checked if it was maybe our fault of not registering them by checking if they were prescribed medication that is only prescribed to ICU patients, or if there was some sort of treatment that is only be done on the ICU. This reduces our list of 54,000 admissions to a little over 20,000. So you lose more than half of your patients, or admissions, not patients, sorry. Is there a difference in what we know about these people? Yes, there is. The age goes up quite a lot. This is slightly cheating because we know that neonatal intensive care was in the first data set, so that is no surprise. We have a lot less missing data for gender. The ICU mortality is greatly different from these 2 sets, and the length of stay is also quite different. So yes, we find that there is a large difference if you actually try to clean, or if you say this is everything we have and find out what is in the data set yourself. The next step would be, what if we put this through the same model? Because maybe your model is robust enough that you will correct for this within the model and the results are the same. This is a thing we don't know yet because we are at the start of this project. And like Yannick said, this is really our way of acquiring funding to do something which we think is very important, and that is to get the source database, so a difficult to work with database, into a form with which we can all work, and especially work together. I already had talks with Yannick about how we can combine this, because it would also be interesting for us to have medication data on our ICU. We have our own ICU medication data, but maybe we missed something from right before the ICU admission. And the overall message that I would like to close this with is something about your data quality. We have been doing this for more than a year. We have been looking into our database. We have been seeing what is in there, trying to get rid of everything that we do not understand, or finding out what it is that we don't understand. So we can already say now, but we hope to improve this even further, in that we can say we know our data and we like to do things the proper way. And we hope you do too. Thank you.
Thank you very much, Frank. Questions?
Well, you indicated that you like to do the thing in a proper way, and the previous speaker, Yannick Nielen, also indicated how do we deal with privacy. This is not indicated at your talk. I think every researcher is struggling with this. Could you comment on that?
Sure. We have looked into this. It's just it's never a very interesting topic to present about. But what has to be done for these sorts of data sets, because we work with two types of data. We work with static data, so the age, the gender of a patient, but we also work with a lot of time series. And there has been work published on this by the group of Amsterdam, how you can anonymize this. And what you mostly need to do is you need to get rid of all the identifying information. So that means use the age instead of date of birth. But also for your time series data, you have to get rid of the timestamps. Because if you know someone was in the ICU at a certain time point, then that is identifying information. So what is most common is that you refer all the data back to, let's say, 1st of January 1900. So all your patients start their ICU admission on that timestamp. So you have to get rid of the static identifying data and the time series identifying data. So we know how to do this. We did this in another project already, but it's just, I didn't mention it in the presentation. But we have a good grasp on that project as well.
One follow-up question, maybe, Joost, and then we'll come to you. Yeah, do you want to follow up? Yeah, we have time, so.
So what you did not indicate is, do the patient have to give permission, informed consent on beforehand? How do you deal with that?
So that is another question. So for these types of large databases, there is the option to you have to ask the EMIR to say if you can get an exemption of getting consent. Because this patient group, this is a patient group that starts in 2013. They are ICU patients. The ICU mortality is around 20%. So it's a trade-off between the burden of calling families of deceased patients or patients that are deceased later and ask them for permission, or make sure you identify or you de-identify all your data so that you are allowed to use it. And in this case, with more than 20,000 patients, the first thing is not really an option. Time-wise, it's not really an option, but it's also not really an option for the burden of the families that we would have to call. So we discussed this also with the privacy officer of the hospital, and the MHTC is aware of that we are planning to do this.
Thank you. Joost?
Hi, Frank. Yeah, thank you for explaining very clearly your project, which relates to frustration to many translational researchers, I think. I was wondering, so you showed that there is quite some dropout that because of reasons that are also avoidable. So what you learn here, will that maybe also turn into a benefit even at table -1, let's say, that when people enter the data, that it's more research, usable, let's say?
And do you then mean that you get rid of people in your database of which you are sure that they shouldn't be in there earlier, or that you do something different to the patients, that you measure more, or that you write down more of their information?
Well, I'm not an expert in this bit, but I can imagine that having a new system like the EPIC system that will come up, can also help to increase the percentage of research usable data, and your analysis will help where to focus on, probably.
Yeah. So one of the downsides and one of the reasons that this project has to be done is because our source database is not clean enough.
Yeah.
But I am also working in the EPIC project, so we are trying to push for cleaner data already when you enter the hospital. Yeah. So that would be a very big step, because then in the ideal world, this whole project wouldn't be needed, but unfortunately it is.
Maybe if I can connect a question to that, because you sort of took out a couple of different groups of patients. I think the most prominent example is, of course, that you excluded the neonates or the pediatric patients. But of course, for a different research question, they may be ones that you'd be really interested in. So how do you feel? Would it not make sense or sort of to have a table 0, A and B, where one is really the wrong information gets excluded, and then of course afterwards you can filter into the research groups that you might be interested in. But here you've sort of combined that into getting to your table. How do you see that?
I think you could do sort of a combined approach, because you have to. It's sort of an iterative process. You remove patients from your list. You have to ask. You have to go to the clinic. Ask, is this what you want? You have to look into specific cases and see if is this really a patient? Is this really the patient that it was marked as the patient that it is? And in these, you can of course save these in between steps and then use them later to branch off into another research topic with another research population.
Thank you. All right. If there are no further questions, then we thank Frank again. And then I would like to thank all three speakers and thank all of you for the discussion. I think it really highlighted what Tilman presented earlier today, that I think within Carim we're really moving to this patient-centered, data-centered research and showing the prominence of that in these kinds of projects. And I think they bode very well for the future. I'm very excited to see what comes out of those. Thank you all. I think we will go for lunch and posters now, and we will reconvene here at 2:15. Any other housekeeping remarks, Tilman? No other housekeeping remarks. See you later.
Good afternoon, everybody. Welcome back. I'm not sure if we can start without the director of Carim. Somebody spotted him? Okay. So welcome back, everybody. I hope you enjoyed the posters. I also hope you enjoyed the lunch, which is, as you can imagine, part of the Exposome. Today is the session 3 in the afternoon. We have a very diverse session. First one will be given by Professor Paul Shiels, manipulating the exposome of aging. After that, we have the Harry Crijns Research Grant, which will also be moderated by Professor Crijns. And the third part of this session will be moderated by Jordi Heijmans, Outcome Survey of the Employee Experience in Carim. It's a pleasure for me to introduce Professor Paul Shiels. And I always try to pronounce his name in Gaelic, because Paul is born in Belfast, Northern Ireland, and then moved to Glasgow. Paul O'Shiel. Do I?
That's not bad.
That's not bad. So he did his PhD in Glasgow, at the University of Glasgow, and as a postdoc he moved to the Netherlands, where he stayed 2 years, working under the supervision of Professor Piet Borst at the NKI, the Dutch Cancer Institute. And he also worked there together with Ronald Plasterk, who is now actually appointed to make a cabinet in the Netherlands. After his 2 years of postdoc, he went back to Glasgow for 1 year and then moved to industry in Edinburgh, to the Roslin Institute, where Paul also worked on the sheep Dolly, among other animals. After that, he moved back to Glasgow, and here he pursued his career. And he has a very established reputation in the field of biology of aging, with over 200 peer-reviewed publications in this arena. His research involves the determining of socioeconomic, psychological, lifestyle, and biological factors that are required for normative aging. He was also the first one to report on this socioeconomic status and nutritional factors affecting epigenetic influences on health. Together with Paul and last year's Reneman lecturer Peter Stenvinkel, yesterday we submitted our ITN, which is now termed Boundless. And Paul, floor is yours. Maybe you can give some insights in the exposome of aging.
Oh. Thank you very much for that very kind introduction. It's a pleasure to be back at Maastricht speaking again. And today I will give you a top-down approach on what my lab has been doing over the past 10 to 12 years. It will be data light, I hope, given the nature of the audience. And I'll flash up lots of reviews rather than data. But if you want to know anything in detail, just ask me afterwards. I'll start today by describing a trinity. So this is a triskelion. It's a Gaelic Irish symbol representing how humans interact with their environment and all its aspects. And I thought it's pertinent today because the Irish approach to science is one that's slightly a view askew. So we're a part of Europe that was never conquered by the Roman Empire. So we have deviated from a linear Roman approach to learning. And it allows us to follow our interests and our nose, as it were. And we take the long way around to many things, but that's often much more interesting and much more fun to do. That probably reflects my approach to science. This trinity can be reflected also in the relationship between Glasgow University, the Karolinska Institute, and of course Maastricht over the past 12 years in an approach to understand how we age in a more holistic fashion and not just understanding
the fundamental mechanisms of aging, but perhaps giving a more rounded appreciation of how our genome and epigenome interacts with our environment across our life course. The third part of this trinity actually comes from Trinity College Dublin, my alma mater. And there, around 100 years ago, the playwright Oscar Wilde, this is Oscar as statue in Stephen's Green, said that to get back his youth, he would give up everything except exercise, getting up earlier, being respectable. You know, I think it's a lovely way to approach the world. I rather like it. But believe it or not, it is pertinent to how we age, not in the way Oscar intended, because exercise, sleep, and lifestyle are critical to our age-related health. That understanding of aging is becoming more important because pre-COVID, as you'll see here, the cost of treating non-communicable diseases between 2010 and 2030 was this astronomical sum, $47 trillion. Yeah, it's hard to get your head around, so 47,000 billions. And that's gone up since COVID, and if you look at that just with respect to the EU alone, it's around 1,000 billion euros per year. And that cost, especially since COVID, is amplified by social deprivation. And resonating with what was said earlier today, the UK government and governments around the world are starting to target this. They all want us to improve our age-related health, our health span, or years of disease-free living, by at least 5 years. In the UK, it's by 2035. That's a very, very tall ask, and has probably been asked by people who are ill-informed to address it. What is nice, though, is the governments are recognizing that there is a health disparity between the affluent and deprived, and they need to close that gap. And that's now being reflected in funding streams within the UK, where there's a need to try and understand normative aging processes and not aging with disease. So in essence, you want to move away from sick care to true health care, whereas sick care, you're really trying to bolt the stable door after the horse is gone. Healthcare, you want to keep the horse in the stable. Today, there are more people alive age 60 and over than at any time in human history. So we're doing something right. Most of those that are in the next few decades going to be 60 or over will be in the global south, the more developing parts of the world, less developed than Europe, the US, and Japan. We already have an older population, and in that part of the world, those over 60 will outnumber those under 15 years old. So there's that demographic shift where our population's getting older. And with that will come a tsunami of non-communicable diseases. And these form a diseasome of aging, where you have distinct disease entities, so cancer, Alzheimer's, arterial sclerosis, heart failure, diabetes, chronic kidney disease, to name but a few. So distinct disease types, but all these, oops, I'm not seeing that. Yeah, oh, okay, I'll move to try and move the slide along. Oh, here we go. Okay. They're all underpinned by a common dysregulation of the aging process. And therefore, understanding how aging goes wrong and being able to mitigate the effects of that is important to, A, preempt the onset and slow the progression of diseases of aging. Now, something has happened with the slides, but I'll plow through this. So how do we age? Aging is highly individual. And I'm always, reflecting on it's very like the start of Anna Karenina. all happy families are alike. You know, all unhappy families are unhappy in their own way. So we all age unhappily. Our aging process is highly individual. And what we want to do is, you know, try and get it to where we all age happily and mitigate many of the factors that drive our aging process differentially across our life course. And we're back working again. So, well, not sure what's happening here. It's coming up on my screen. Can you see it? Okay. Like, it's white here, but I'm not seeing white there. So you can think of aging as an accumulation of deficits taking place in different individuals in different ways with a variety of different rates for different organ systems. Quite a mouthful. It's a definition coined by Graham Pavelik's lab about 15 years ago. But it does work. So if you think aging starts pre-conception and ends at death. So what's happening when your mom was in your grandmother's womb and you're a developing egg in your mom or a developing egg cell? Environmental exposures and lifestyle that your grandmother is subject to affects your mother in her womb, and then those effects are translated to you a generation later. So aging starts pre-conception, ends in death. It's not passive, it's active. And if you can understand the underpinning molecular and cellular biology, then you can intervene and you can improve how you age. You can slow down the rate of it and better your health at an older age. And therefore, it is essential for understanding and maintaining good health in old age. And this is the Shiels trajectory of aging, age 10, age 40, and age 60. And I show this because I like to think that my aging trajectory is malleable. Having grown up in the adverse circumstances in a war in Belfast as a child, I can improve my health characteristics as an adult by changing my lifestyle. Aging can be hallmarked the way cancer can, or has been. And there are now 12 hallmarks of aging that are common across taxa, so common to flies, yeast, worms, mice, humans. These are things such as telomere erosion, accumulation of senescent cells, mitochondrial dysfunction, dysregulation of the epigenetic landscape, microbial dysbiosis, and an increase in low-level chronic sterile inflammation called inflammaging. If you can intervene in the aging process, it's been calculated that you can add 25 years of good health to an average 50-year-old woman, whereas if you cured cancer or heart disease, in reality, you'd only add 2 to 3 years of healthy living to that individual. And the economic value of being able to do so, again, is quite staggering and therefore has attracted interest from governments and pharma. An understanding of the hallmarks of aging, while important, is not the whole picture. So if you think of our body as being like a car, where we are at the moment is when things go wrong, we can fix most of the bits in the car and keep it on the road for a long time. What we can't do is repair this, putting the car in the wrong environment at the wrong time and it gets trashed. So that's really the impact of your exposome. And the exposome comprises your totality of environmental, both biotic and abiotic exposures across your life course. And in the context of, for example, cardiovascular health, it encompasses the air you breathe, the food you eat, the environment you live in, and your relationships within that. And its importance can be emphasized by the fact that 3 simple exposome factors account for around 50% of global deaths annually, and that's really air pollution, tobacco smoke, and an imbalanced diet. And I'm now going to show you what I call my candles and crystals diagram. as someone who is trained as a bench scientist doing wet work, it's forced me to have an appreciation of what's happening in the wider environment. And that is often very difficult to grapple with. So the impact of your exposome is mediated, for example, through your relationships with your parents and siblings when you're very, very young. So you can ask, are your parents nurturing or are they abusive? Is your wider family nurturing or abusive? What access do you have to good education in a safe environment with green spaces and good air quality? All of these things, including your wider social environment and access to transport, to sports facilities, community events, and an interaction with a spiritual environment. Those that live the longest and the best health are often quite spiritual, and that's globally. And that, for those of us that have grown up in a laboratory environment, is often a very hard interface. But it's important. So, looking at this exposome approach to understanding age-related health, at least for me and in the city I live and work in, is actually critical. Because Scotland is the sick man of Europe, and Glasgow is the sick man of Scotland. And if you look at deaths per 100,000 in Europe, this red dot is is it on? Yeah, we're here. This is Scotland, sitting just below Albania. And you can see, death rates per 100,000, second worst in Europe. If you go to the right-hand side here, you can see by council area in Scotland, most areas do quite well, but the picture's skewed by the east end of Glasgow. This top dot is Calton, where average life expectancy for a male at birth is 54 years, which is a disgrace in any part of Europe. Amazingly, within a 12-kilometre geographical radius, we have the best average life expectancy for a male in the world. It's more than 80. So within the city, we have the best and worst conditions for healthy life expectancy. So what's causing this? How does the environment impact upon age-related health? For example, in the worst part of the city, Calton. And Calton's quite a famous place. This picture is of Brother Walfrid, a man called Leo Cairns from Sligo in Ireland, who founded Glasgow Celtic Football Club. He founded it as a charity in 1888 to put food on the table of the poor. And here we are in 2023, and the club is still a charity, putting food on the table of the poor in Calton. 12 kilometres away, we have Lindsay, and you can see Calton is pretty deprived, not a nice place to live. Lindsay is green, leafy, with nice housing. People live long lives. So how do you measure the impact of the differing environments on age-related health in those two communities? How do you intervene to improve the health of our least deprived? And how do you measure efficacy? And over the past 10 to 15 years, we've been wrestling with that problem. So this is the Glasgow Exposome. If you look at our deprived, they tend to be heavier. They have an imbalanced diet. They do not eat the recommended 5 fruit and veg a day. Eating 5 fruit and veg a week for many of them is a challenge. They are more sedentary. Their lifestyles are not conducive to good health. They often smoke a lot and drink a lot. Whereas the affluent tend to be lean, exercise, have a balanced diet. They're also less inflamed. As I mentioned, chronic low-level sterile inflammation or inflammaging is a feature of age-related health. And in a range of studies now in the city, when we look at the general population, not a clinical population, the relationship between biological age and inflammatory burden is not linear. we can explain less than 10% of the individual variation in inflammation by biological age. And it's allowed us to focus more on the factors that are associated with accelerated aging in that community, in the deprived. And that's typically low income and imbalanced diet. Historically, if you go back to Hippocrates, there's always been a link between food and health, a link between fasting and health. But Hippocrates said that all diseases begin in the gut, and that resonates with what the Lancet 8 Commission was telling us, in that 22% of global deaths in 2017, when the report was commissioned, were linked to imbalanced health, and it made it a rather easy lever to start pulling on or pushing on to try and improve age-related health. Lessons on how to do so can be learned from going to the animal kingdom and asking what happens when you have an imbalanced diet, if you're a human. So we are descended from frugivorous apes, and we have become omnivorous as we have dropped down out of the trees and spread around the world. However, many of us, especially men, think they are obligate carnivores, like a big cat. So what happens when you are an obligate carnivore? If you look at the cats, they tend to exhibit phosphate toxicity. Almost 90% of them will have some form of kidney disease. 50% of them will have colorectal tumors, and they will have an elevated inflammatory burden. And that phosphate toxicity is important in that the more phosphate you have in your circulation, the shorter your lifespan will be. And you can see that across, here we are, most of the mammals. Human centenarians tend to have lower phosphate levels than the average man. Human progeric mutants, and here we see an example of Hutchinson-Gilford's progeria system, where the average life expectancy is 14 to 15 years old. Elevated levels of serum phosphorus. And go back up to the renal mutant, Clotho. It's a small animal, lives 12 weeks. If you knock out the phosphate transporter, it will live 2 years. Put it in a high phosphate diet, it will live 12 weeks. The relationship between nutritionally acquired phosphate and lifespan is very strong in mammals, and it's not reflected in the hallmarks of aging. If you go to Glasgow, men that eat red meat too frequently live approximately 30 years less than those that don't. That's reflected in their renal function as expected. It's reflected in their biological age and their inflammatory status. We can see here the downward trajectory of telomere length with age in that community. Interestingly, the deprived also in the general population have renal function equivalent to mild to moderate kidney disease as a consequence of eating too much red meat. And just like the big cats, we also see this association with an increased prevalence of colorectal cancer. Interestingly, if we could shift their dietary habits and get them to eat more plant-based protein than animal-based protein, then we may improve cardiovascular health, renal health, and reduce mortality. And that's also backed up by studies of colorectal cancer within the UK as well. So shifting away from eating too much red meat should reduce the incidence of colorectal cancer in the general population. Eating red meat and the carnitine that comes with that brings an additional problem. Carnitine is processed by gut bacteria to generate a highly pro-inflammatory compound called TMA. TMA is processed in your liver to TMAO, and that's been associated with poorer cardiorenal health, chronic kidney disease, and more recently, rheumatoid arthritis. Just check my time. And in the Glasgow population, where we have this accelerated aging, we have got increased levels of phosphate, more inflammation, the imbalanced diet, then on the same biochemical pathway that generates TMA, on a different branch is betaine. And betaine provides methyl donor groups for maintenance of your epigenome. So the methylation in your DNA is acquired from betaine feeding into the methionine cycle. And indeed, if you look at the Glaswegians again, compare the deprived and affluent, are deprived with accelerated aging of less methylation on their DNA, which begs the question, do they have a dysbiotic gut? Are there differences, in the microbiome between the affluent and deprived? And indeed, that's what we see. The deprived here have less betaine. And interestingly, if we look at bacterial DNA signatures in the blood, so these are bugs that have leaked in through the gum meninges or through a leaky gut, what we observe is our deprived have more oral pathobionts, so bacteria that generate adverse health characteristics. So things such as Rothia that have been associated with endocarditis, Porphyromonas associated with Alzheimer's, and Neisseria associated with chronic kidney disease. All of these make TMA. The affluent, on the other hand, appear to have more Lactospiraceae, Lactobacilli, and Pantoea that can make betaine. So there is a difference in their microbiomes. Interestingly, the mechanistic basis of the salutogenic or health-promoting effects are understood in that the salutogenic bacteria can break down fruit and veg, generating polyphenols that can be converted to alkyl-catechol that activate NRF2. And NRF2 is a transcription factor that regulates almost 2% of your genome and all of your cytoprotective responses. So this is now a major target for xenotherapies that are wanting to enhance your health span and the rate at which you age, so to give you better biological age at advanced chronological age. Interestingly, the Western diet does not well support the growth of these salutogenic bacteria. Typically, they are supported by pickling and fermentation that one sees associated with more traditional diets in less developed parts of the world. So eating things like kimchi or drinking chicha and other fermentation products is actually good for us, and this is one of the reasons why. So I'm going to move on to sort of a second part of this talk, which is to really address how to measure interventions to improve age-related health. What's the best way to measure how we age? And currently, the range of markers we have available are not ideal for, again, working out how many miles we have on the clock. So they're not good as an odometer. And they're also not good as a speedometer, measuring our rate of travel. And more importantly, they're not always good at distinguishing between normative aging and disease, or accelerated aging with disease. And there are a range of markers out there that range from the biophysical, such as gait speed or chair rise, to a measurement of lens density. And lens density is now feeding into M-Health, because you can use a smartphone app just to take a picture of your lens and have an algorithm calculate its density. And it correlates very well with chronological age and other features of normative aging. And it's one that will appear over time. And it's something we developed with Sophia Patai here, who's now VP for Medicine at Evolution, doing very well for herself. But it is a non-invasive way of measuring miles on the clock, whereas the biochemical measures we have are often very weak. And these include things like telomere length that's been used widely, CDKN2A, which is the transcript for the P16 protein. That's an on-off switch for the cell. So the more cells you have in growth arrest, the less function you will have. We have things such as skin autofluorescence that measures age glycation end products, widely used in clinical settings now. And we have phenotypic age, which is a combination of blood-based biomarkers of generally inflammation and blood cell counts. We've also got a range of proteomic markers, metabolomic markers, and now microbial metabolite markers. But not all of them work well. And we have tried to apply them head-to-head across the board over the past 10 years using the kidney as a model of aging. And if you go back to the hallmarks, what we have done in chronic kidney disease, starting at stage 1 when the kidney's still working relatively well, through to stage 5 where it's not and you're needing a transplant. There is a differential in aging across each of the stages of the disease. And even when you have your transplant, you're still not back to a normative status. But what we see in that progression through kidney disease is telomere shortening, increased inflammation, more cellular senescence, mitochondrial dysfunction, changes in the epigenetic status of the organ, and microbial dysbiosis, all that match the hallmarks that have been observed in flies, in yeast, in worms, in mice, and that are common now to men. And in work, we initially started this in Maastricht with Jeroen Koeman and also Casper, who's sitting in the audience. And the hallmarks link in with features of physiological aging that you see in humans. So aspects of frailty, so it's loss of muscle mass, osteoporosis, a greater inflammatory burden. And if you compare all those features with the hallmarks across different organ systems, what we observe is when you have chronic kidney disease, your biological age is about 5 years ahead of your chronological age. So any measures of aging that we have should really reflect that. And that can be gauged in terms of a chronological change in the level of normative kidney function. So we have asked then in head-to-head comparisons, if you treat CKD with dialysis or eventually with transplantation, do you ameliorate this acceleration in aging? And how do the markers of biological age compare head-to-head? And importantly, do they really report properly changes in normative aging and not overt disease? And using a kidney transplant as a source of healthy tissue allows us to address this component of normative aging because it's not diseased tissue. So if you can look at, for example, skin autofluorescence or phenotypic age, the answers you get back are generally nonsensical. So skin autofluorescence, for example, suggests that people with CKD5 are 200 or equivalent to 200 chronological years old. Nonsense. Phenotypic age, 110. Again, biologically implausible. So we have moved to look into DNA clocks. And epigenetic clocks have been around now for 10 years. First generation clocks, the Hannam and Horvath clocks, both come out of Steve Horvath's lab, are trained against chronological age. And more recently, second generation clocks have emerged that are trained against chronological age and a range of biochemical markers and lifestyle factors. For example, how many packs of cigarettes do you smoke a day or a week? And they are great at showing you a disconnect between chronological age and biological age, but they haven't really been tested head-to-head and haven't been tested in the context of normative aging. And we tried to do that. And I like showing this picture because what we did was describe this groundbreaking. It's not, but it's nice to see the press report it this way. We just took individuals at different stages of chronic kidney disease through to CKD stage 5 when they needed a transplant, and then compared them at transplant and 1 year after transplant using all the clocks to see if they accurately reflected the speedometer function, how many miles it accumulated, sorry, the odometer function, I should say, and not the speedometer, and then the speedometer over the year to see at what rate they were aging at. And this is really what we got back. We got a very, very close match with chronological age in all of them. So they all work relatively well. But when you actually compare them longitudinally in an analysis of dialysis for 1 year versus transplant for 1 year, what you observe is that the clocks that were first generation, so the Hahnemann-Horvath clocks, are not accurate. They show that disconnect between control and CKD, so there is a difference between biological and chronological age. But with transplantation, where we know after 1 year the individuals are physiologically better, they're much more robust than those that are still on dialysis, where you have a 50% chance of survival over 3 years. So you are on a steep downward trajectory. The second generation clock pheno age actually does show that transplantation slows down the rate at which you're aging, but as you can see, it doesn't do so very accurately. Whereas a composite clock, which is the best of all the available clocks, does this quite well. And it tells us that if you have chronic kidney disease, you are indeed about 5 years biologically older than your chronological age, but the rate at which you're accumulating miles in the clock slows to normal following transplantation. And on the left here, you've got a clock called Grim Age, which is regarded as the best of all the clocks prior to this. Shows no difference between having a transplant and being on dialysis. So again, it's not accurate for normative aging. And where we are with this is that we now have a tool that we believe, this composite clock, is good for tracking interventions and accurately monitoring the disconnect between biological and chronological age, and then any improvements that you may see if you have a sentinel therapy. And we're now assessing this in a general population cohort of 5,000 individuals in a longitudinal analysis. And hopefully in a year or two's time we can report on that. In the interim, finally, I'll finish off by telling you a little about some of the interventions we've been undertaking. Again, in collaboration with Leon Skurgers here in Maastricht and with Peter Stemwinkel at the Karolinska Institute, looking at a range of sentinel therapies that are either naturally occurring bioactive substances or drugs that can remove senescent cells from the body or mask their effects, or drugs that can activate NRF2 and thus up your cytoprotective responses, or other agents that interact with other aspects of the exposome, either changing your geophysical environment or changing your lifestyle, or combinations of both. And food as medicine within this has become a real strategy again, because if you look at the animal kingdom and you look where animals either live a very long time, long-lived species, or species that live in adverse environments, they tend to modify the activity of NRF2 to allow them to adapt to their environment. And they do that either by altering their diets, excuse me, or having a way of modifying the epigenetic regulation of NRF2 to enhance its activity. And we have been trying to do this either directly using bioactives or indirectly by manipulating the microbiome using prebiotics to generate or enhance the growth of bugs that are salutogenic and whose metabolites can activate NRF2. And this approach has received recent support in a retrospective analysis of dietary patterns and lifespan within the UK. And John Mathers and his colleagues have just reported that potentially life expectancy can be increased by up to 10 years just by shifting diet to one that includes less red meat and eats more leafy green vegetables and grains. And that synergizes with a lot of what we have been doing for the past 5 years. And I'll exemplify that by showing you how we have approached this in collaboration with Denise Mafra's group at Fluminense in Brazil, whereby we're trying to enhance the health span and extend the lifespan of people on hemodialysis. We will have this 50% survival over 3 years. And we're doing that by giving them prebiotic cookies. And these contain inulin as the prebiotic. And inulin is used as a substrate by saccharolytic bacteria to produce short-chain fatty acids that can diminish the level of inflammation in these individuals, and that can also produce metabolites to activate NRF2. And what we observe after a short 4-week treatment of administering the prebiotic cookies is that we see enhanced growth of lactosporiaceae and lactobacilli associated with the production of metabolites to activate NRF2 and therefore reduce inflammation. So simply, we're supporting the growth of salutogenic bacteria, so shifting the community of bugs in the gut rather than trying to dump in new bugs via probiotics. And we've also done this using propolis from beeswax, which is a mix of polyphenols. And the polyphenols, again, are being converted by gut bugs to generate activators of NRF2. I'll not show data for this, but I can go through it if anyone's really interested. The approach in a randomized, controlled, double-blind clinical trial works. It's a small trial, but it's a lovely first step. And that's something using the foodstuff that we can carry into the general population. Interestingly, this approach to modify the microbiome can also be achieved by fecal transplant. And in preclinical models, there's some really nice data now showing that you can actually reverse some of the hallmarks of aging, at least in mice, using fecal transplants from young mice to older mice. But one should be able to achieve the same effect simply by identifying the appropriate metabolites to do this. So I think I've taken up enough of your time. I will conclude by basically saying that the exposome is really a powerful mediator of aging and health. It's malleable, and the manipulation of the exposome is not that hard to do. And we now have some suitable tools, especially a composite epigenetic clock that should allow us really to track longitudinally the efficacy of interventions in this whole field and remove a lot of the sort of smoke and mirrors around the more popular attempts to do so that you may read about in the general press. And I'll finish by quoting Flann O'Brien. I love this quote. It says, "Your talk is surely the handiwork of wisdom, because not one word of it do I understand." And given my accent, I think for some of you that might be a problem. But thank you.
Thank you, Paul, for this wonderful presentation. I all hope that you took the veggie sandwiches during lunch and not the meat sandwiches. The floor is now open for questioning. Any questions from the audience? Barend?
Thank you very much, Professor Shiels, for this interesting lecture. I was wondering if the red meat hypothesis or proof that you show us, if this has been validated in other cohorts than the Glasgow cohort. So, for example, in the US population, which is potentially less socially lower class, but eats a lot of red meat.
So it's not just in Glasgow. There's a Himalayas of evidence from nutritionists out there that consumption of red meat is linked to an earlier emergence of the diseasome of aging. But it is the red meat from domestic ruminants that's the issue here, is not from eating game. I think there's, at least from my perspective, there seems to be inference that we should eat less meat all round, but we are essentially, we're omnivorous apes. We are not vegetarian. But our change in dietary habits, especially with the emergence of ultra-processed foods, has outstripped the rate at which our microbiome has adapted to, evolve with us. And we're not really aware of all the adverse outcomes of that yet, but part of it, I think, is because, our red meat consumption, and certainly processed red meat that contains lots of inorganic phosphate preservatives, is causing gut dysbiosis and triggering other events that we don't fully understand yet.
Thank you. I have a fundamental question. Why do we aim to increase our lifespan? Because if we increase our lifespan, we increase the burden to future generations. And so at the end, the problems accumulate. Why do we not aim to a shorter lifespan? Perhaps we should equally, there should be perhaps a more fair distribution, because some groups are living shorter than others. But why do we aim at a longer lifespan? I think we should perhaps aim to a shorter lifespan.
So, and it's an interesting question. So, what I would say is we're not aiming at a longer lifespan. We are aiming for improved health span, so more years of healthy living, and we wish to compress morbidity at the end of our life. I think there's a lot of popular science and science on social media platforms that says we can extend lifespan. I think that's science fiction. We have enough fuel in the tank to get us out to 120 years. None of us make it that far. Most of us will, in this generation, make it into our 90s, and we want to make it into our 90s in better health than previous generations. So I would say, in general, the field is not moving to increase lifespan. We don't know how to do that yet. Whether or not we should do it is another matter. I think we are morally obliged to improve people's health in old age, because if I presented with cancer at age 50, I would be treated. If I presented with cancer at age 90, I would want to be treated, and I would feel I would have the right to be treated. We are not seeking to add extra decades to people's life. I think that is still science fiction, and people that claim they can reverse aging are being very misleading. We can slow down the rate at which we decline, I think, is the best way to put it. And should we have shorter lifespans? I would say no. The planet can support enough of us. We have, potentially the technology and the will to improve how we live on the planet and with the planet. If you think, currently, we spend so much of our time, effort, and energy producing food for animals to eat, for us then to eat the animals. That's not a good way of doing things. There's enough agricultural capacity in the planet to allow people to feed and eat well and have good health for at least double the current population of the Earth without using any more land. And I think we should readily be able to do that. But with respect to increasing lifespan, we can't do that yet. I mean, we're not living any longer than the biblical 70 years and 10, really, for most of us. But I think this generation, given that we can show that aging is malleable, we have got good interventions that are well on the way to removing senescent cells that are causative for non-communicable diseases. That should allow us to live healthier for longer, but not live longer per se, if that answers your question.
Thanks, Paul. I don't want to picture really as a food guru, but I still have some questions about this red meat discussion. I mean, I don't eat red meat, not because of my health, but because of the planetary situation. And we have red meat, we have TMO, we have processed meat, and we have phosphate. That's like the four corners of my little anti-meat world. So what is now the predominant risk factor? Because say game is not the issue, that's pretty harmless. Then I think if you have processed meat, in which maybe the phosphate is the bad component, what happens then with all these nice food replacement things that are also
processed, like all the conservatives, everything is in there except meat, but then in this case soybeans. So would that be as harmful as processed red meat if we take out GMO out of the equation?
It's a really good question. I can only speculate on that because we do not know, because our aging and health is so heterogeneous and gradual, we don't know how to model it to get quick answers. And replacing, so I would say, one, we need to remove some of the inorganic phosphates as preservatives and go back to traditional methods. The number of inorganic phosphate additives that are deleterious are probably small in number, at least from our studies. We have in Glasgow a drink called Iron Brew. It's littered with inorganic phosphates. It's the only soft drink that outsells Coca-Cola locally anywhere in the world. So if you had adverse health in Glasgow among our deprived that drink loads of it, we thought, this is a problem. And I love Iron Brew, so I was kind of worried. But the additives in it are not associated with the increase in aging. It's additives in processed meats. So it's the fast food burgers and other products that are an issue. So removing those may help. Replacing aspects of red meat with soya-based protein or plant-based proteins. Again, that could have adverse consequences if it affects your microbiome, and we don't know how, what the long-term impact of that will be. But simply by changing to eating, more colored vegetables and a greater variety of vegetables and grains should work. I mean, that sort of retrospective analysis that John Mathers and co did indicates that. The alternative, of course, is to eat lab-grown meat or vat-grown meat and vat-grown plant protein. But I think early indications are that that does not support a normative microbiome, even though there's a lot of money being pumped into it. And I don't know what that would even look like to eat. I think, one thing that we didn't really touch on here is psychology is really important. So psychological stress is a massive driver of how you age. So if you're a long-term carer, you're going to knock 15 to 20 years off your life expectancy just through accumulation of lifetime stress, cortisol mediated. And it's one of the reasons why biopsychosocial interventions work so well, is that you are reducing that level of stress. Right. So it's the all things of moderation. And back to Hippocrates again, exercise, food, not too little, not too much, but just in the right amount is the best way to good health. So cutting psychological stress is a player here, and therefore eating and enjoying food, and especially being social in that context, is also very good for you. Because if you go to centenarians and you ask them, what's the secret of a long life? What things, do you think give you better health than your peers? And it's being social. Yeah. Cutting psychological stress. It's probably why women live longer than guys, because they handle stress better.
So life may get longer, but surely more complicated.
Yeah.
Well, it's good that we have our Carim family, that we all are very social here. I think for the sake of time, we have to move on. Paul, thank you very much. Another round of applause. Thank you. And then I give the microphone to Professor Crijns.
Yes. Thank you very much, Leon. It's my great honor to announce this year's Harry Crijns Research Grant winner. This is for the third time we have a winner of this grant. This grant aims to support early researchers in the cardiovascular and cerebrovascular field. It's very important we do that, to attach these young people to us. And this year the winner is Carim Robbe. There she is. Carim, come forward. I met Carim for the first time when she pitched, and we asked her, where are your slides? I don't have slides, she said. I thought this was a pitch. And this is what you did. And not only she gave a wonderful pitch, which word for word we could follow very well. Thank you for that again. But we also chose her then for the topic, which she will present in a minute, which is very forefront, aiming at diagnosing better special neurological patients. And I'm not gonna do your speech because it's too difficult for me, but we liked your topic very much and we think you will be very successful. Before you get the opportunity to explain your research, I want to hand over the certificate which comes with this prize. And we're going to make a picture, right?
Research will take 10 minutes and thank you very
much. So thank you very much for that introduction. The upcoming minutes I'm going to talk to you about the choroid anterior artery, or ACA as I will call it, occlusion and prognostic implications in acute ischemic stroke. Because imagine, your 50-year-old aunt suffers from an acute ischemic stroke. In the acute moment, she's rushed to the hospital and she is undergoing acute treatment, such as thrombolysis or thrombectomy. Post-treatment, the focus shifts to revalidation therapy to help your aunt gain functional independence again, which is usually expressed using the MRS score as you see above. However, despite the immediate therapy and the may or may not gaining of functional independence again, a significant number of patients and stroke survivors are left with memory complaints, cognitive decline, and depression. This scenario, unfortunately, is all too common for individuals who have experienced acute ischemic stroke. In my research, I aim to improve functional outcome of patients with an acute ischemic stroke. And as a neuroradiology PhD, I'm always very excited about radiographic markers. And there are a lot of radiographic markers for acute ischemic stroke and poor functional outcome. However, there is one that I really would like you to remember, which is the aspect score. This is a quantification method that divides the middle cerebral vascular territory into 10 different parts. And you can use this quantification system for different radiographic markers, as one is contrast extravasation. A colleague of mine showed that a low aspect score, which means more regions which are involved with contrast extravasation, leads to worse functional outcome in patients. However, we have found an additional region that can show contrast extravasation due to a middle cerebral artery stroke and is not in the aspects region. This is the mesial temporal lobe. The mesial temporal lobe is part of the temporal lobe and it involves the limbic system. There are structures in the mesial temporal lobe as the hippocampus and the amygdala associated with memory and emotion. And we have shown that if patients show mesial temporal contrast extravasation, they have an additional odds of a worse functional outcome, even without all the other aspects region. So this is a very important structure and there's not really much research about it. So we believed we should do more research about this specific mesial temporal part of the brain. So what do we know about this mesial temporal lobe? Well, it is supplied by the ACA, which is a very small vessel, which only has a diameter of approximately 1 millimeter. It is the last branch of the internal carotid artery and therefore is usually passed during a thrombectomy. So with all this background information, I come to my research question. Is an occlusion of the ACA associated with mesial temporal contrast extravasation, infarction, and long-term cognitive decline and depression in acute ischemic stroke? But first of all, we have to see how often can we even see this vessel. It's only 1 millimeter small. It's super, super small. Well, obviously, as for sake for this presentation, I have picked the best possible example I could find. And you see, it is very small, but you can see it. But in daily clinical practice, this is not as easy as it looks. And also, because of this small diameter, up until now, you can see it, maybe not, on the conventional CT angiography. But now we have, since May actually, we have the opportunity to scan patients with the photon counting CT in Maastricht University. And look, you can see the ACA with the red, arrow. So what do we want to do with our study? We want to add an extra scan to the stroke imaging timeline. We want to add a 24 hours photon counting CT-CTA. Because on this scan, we can assess whether the ACA is occluded. We can compare this to the baseline scan and see if this ACA remains occluded, is open, or is occluded due to the endovascular treatment. Moreover, we can find out if the mesotemporal shows any signs of infarction. If we can see an ACA occlusion, we can associate it with mesial temporal contrast extravasation, infarction, and ultimately to cognitive function, scored, for example, with the MoCA score, and the Hamilton Depression score. So if our hypothesis is accurate, and we can associate it to long-term cognitive decline and depression, we can allocate resources and provide more extensive counseling to patients, to family of patients, and to treating therapists. Moreover, we may be able to advise the interventional radiologists to heighten their caution about this specific vessel, for example, due in stentement placing during the endovascular treatment. I'm super grateful from the support I got from the Harry Crijns Foundation, which gives me the opportunity to continue this research in the following upcoming years. And I hope to provide deeper insight into cognitive decline and depression in acute ischemic stroke patients, and optimistically and hopefully improve patient outcomes. So I also want to thank, of course, my study team. I'm not doing this alone. And if there are any questions, I'm happy to address them.
Thank you very much. I'm impressed again. And so, are there questions from the floor? Yes, a lot. Go ahead.
Thank you so much. This was really fascinating. I learned something I totally didn't know before. I wonder what you think about the pre-stroke cognitive function in these patients, because people at risk for stroke have subclinical atherosclerosis, so they might have chronic occlusion of this particular tiny, small vessel. So they might already be cognitive impaired before their stroke. So I wonder, and we've learned, I'm not going to talk about it, I think, in my presentation at 4, but people with cognitive impairment have a higher risk of stroke as well. So I wonder if you're able to think about that or how you might approach that.
Yeah, that's a bit difficult because we don't really know when a patient will get a stroke. So we don't really know when to test for cognitive decline and depression before stroke. The only thing we can do is we can compare it to the baseline CTA. And at that point, we know if it was chronically occluded already or not. But then at least already a patient has a stroke, so it can also be occluded due to the stroke. But that's a good comment, but that's very difficult to do. Yeah, definitely. Thank you.
If there's no more questions, thank you very much. And we really all wish you the best in your research and
thank you.
Your PhD trajectory.
Thank you. Thank you.
I hand over to Jordi Heijman. Jordi.
Very good. Good afternoon, everyone. So it's my great pleasure. I'm standing between you and a coffee break. I'm very well aware of that. I will make sure we don't run over time. But I think it's good that we have a little bit of time to briefly present you some results of the survey that many of you contributed to and that we set out as part of the one of the questions that was raised in the strategic board. Well, this is what you find on the website and in the annual report about what the strategic board does, but I think if we kind of rephrase that, I would say that we try and reflect and advise on how Carim can continue to excel. Current members of the strategic board are shown here. Many are present today, and we have been active now with slightly varying composition, but with many of these people over the last few years to address some of the central questions that I think have an impact on all of us in Carim. Some of the previous and ongoing initiatives include that we have assessed and looked at some of potential missing expertise and required infrastructure. And you heard this morning from Tilman's talk that, for instance, that has resulted in investments in the data science expertise. We have contributed to shaping Carim's position and recognition and reward. And as you also heard this morning, over the last little while, we have had quite some ideas and thoughts and discussions on Carim's position on diversity, equity, and inclusivity. And that, as you've seen this morning, I think has resulted in some very good spin-offs and follow-ups. Over the last little while, we have been discussing evaluating the workload and job satisfaction in Carim. And of course, this is not necessarily a very new topic. I think many of you will have seen this in various publications or things that you read online, that there is this growing national, international, and also local discussion on workload and work pressure in general in our lives these days, but particularly in academia. What you see here on the right-hand side is in Dutch, so apologies for those who don't speak that, but it's a national survey that was held a couple of years ago, done by Statistics Netherlands, and from requested by the government, where in people in higher education, but also in academia and in research, what kind of work pressure was felt. And the conclusion was that this was particularly significant. This also applies to different universities who have made statements on that or who have groups who particularly look into this topic. So why should we do this at Carim? What was the motivation for us to say, well, maybe this is something that we should also assess within Carim? As a strategic board, we received signals that also within Carim this might be a growing problem that of course affects individuals, but it also is important, and that is one of the reasons we discussed it also in the strategic board. It may also be important for Carim as an organization, because of course if this negatively influences the performance of our Carim members, then in the end this may also reflect, for instance, if there's too much work spent on other things, they may not be able to get the grants that we need for Carim to be successful. So I think it affects many people at many different levels. And as good scientists, we want to quantify these things, we want to know these things. In Dutch, meten is weten. So we want to get a feeling for that. And so that was one of the motivations to set out this survey among people appointed at Carim. Because ultimately we believe that it's important that we, where possible, and we'll come to that to the final slides, of course that's not an easy task to really address, but still that it is important to keep a perspective towards maintaining sustainable research time for the people at Carim, for people's own individual benefit, as well as for the research organization in its entirety. So what did we do? We designed, in collaboration with Human Resources, a relatively short survey, which was then refined, conducted, and analyzed by Flycatcher, so it was completely independent and anonymous. And as a strategic board, we only received the aggregate results. This was done earlier this year. It was sent on May 16th, reminders on May 23rd and May 30th, and then it could be filled out up to and including June 5th. This was sent out to 278 individuals. One of the decisions was made that we would only send this out to people who have at least a 0.1 FTE appointment at Carim, because if you have external people who just are, have their I don't know what it's called now in English, but where you are an external PhD student, for instance, your situation is different. It may not really reflect the work at Carim. So that is the list that was compiled. 278 invitations were sent out, 123 complete responses, or 44%, which I think for a survey of this kind is a pretty decent response and suggests that this does reflect at least part of the Carim population. So I briefly, there's of course, these results are interesting and there's many things to say, but I just want to give you a little bit of a flavor with some of the general ideas that came out of that. If you look at workload, one of the questions that was asked was the experience of workload related to the position, and about 74% of the respondents rated their workload as high or very high. Particularly if you look at the level of assistant professors, associate professors, or full professors, this level was 100%. If you look at how often people are exhausted after work, this was rated as 44% saying they were often or very often exhausted after their work. And 57% of individuals indicated that their perception of workload had increased significantly over the last 5 years. Well, this feeling of the increase in workload or work pressure, where does this stem from, or which activities may contribute to that? That was some of the other questions that we asked. So what part of your position is labeled for the core activities that we have? Teaching, research, for some of us clinical work, and other roles which mainly was interpreted to include management and related tasks. Then people listed this as their official labeling, and what you see on the right-hand side is what was labeled as the time that was actually spent on tasks. And you can appreciate from this that that is significantly more than what was labeled, by about 24%. And if you again break that up in different subgroups, then 83% of the professors said that they very often work during their free time, and there the labeling was, instead of the 0.94 FTE officially labeled, it was actually spent 1.29, so 37% more. So, numbers are a little bit abstract. I think this, when we discussed this within the strategic board, one of the members phrased it like this, and I think that makes it quite tangible, that you can say that Carim employees on average work 1 day per week more than their labeling, and this is primarily, if you look at the breakdown of the tasks, to address those other tasks. So this is one side of the medallion, and that there is, I think, a significant workload. But there's always a flip side to that medallion. And that is also addressed in this survey, and that's also what many of you responded to. So if you look at the job satisfaction that comes with the job, this actually looks quite positive. So 49% said that they enjoy their work a lot, 66% that they enjoy their interaction with colleagues a lot, and 61% that they enjoy the content of their work a lot. So I think, and from that perspective, people are quite satisfied with their work at Carim. Again, here we looked into which tasks are then the things that people like best, if you will, and then you see that, yes, we are really researchers, and that is the thing that we are very motivated to do, and almost all of us that have that task really like it a lot. So if I sort of put all those numbers and kind of the key take-home messages together, as I said, there's two sides that are in balance here. We have a high workload with the high number of people reporting that they're exhausted after work. The extra day per week that is being worked to address these other tasks, and the perceived workload that has increased significantly over the last years. The only breakdowns we had, of course, also due to the number of respondents, is that it was broken up between men and women, that there were no real major differences there, and that it was broken up into 3 groups, so support staff, PhDs and postdocs, and faculty, and there I showed you the significant differences for the group of assistant associates and full professors. Despite this high workload, most respondents are very positive about the various aspects of their jobs and the activities that they perform, and as I said, that is mainly research. So, where does this take us? Well, I think it is something that, at least when we discussed it within the strategic board, we said, well, these are numbers. Of course, the general message
wasn't that surprising. I think that is something that we, as I said, we heard these signals about work pressure, so that it is perceived to be high, I think was in line with expectations, but the extent of it was maybe still something that surprised us. So this has been discussed and brought to the daily board since then, and further discussions with human resources and other groups are planned to help us put these results in context and expand the reach of these findings. But what we also discussed is that I think it provides a starting point. Provides a starting point for all of us to make our voices heard in surveys like these. As I said, 44% is not a bad response, but it also means that there is a large group among us from whom we don't know how they feel about this. And so also for those people, if this is something that affects them, I think it's important that that is known in these kinds of surveys, but also in discussions with supervisors or when new tasks are added to the long lists. And I think this is something that, given the impact, as I mentioned earlier, for individuals and for the organization as a whole, is something that, well, at every level we need to keep an eye on, for supervisors as well as also for the daily and strategic board. And I want to make use of this opportunity to indeed let you know that if you're interested in following up on these things, then keep an eye, and that we have currently a vacancy for a position within the strategic board. And please respond to Tara for that by December 6th if you're interested in. So I think, in general, this is a complex topic. It will certainly not be a one-size-fits-all solution, and for some, of course, there may not even be a problem with this workload. So I think it is very heterogeneous, but I think it is something that that deserves attention, and it deserves our attention because of the impact it may have on individuals. And I think with this survey, we have a starting point, we have a reference point of how we feel now. Of course, there have been many initiatives, and many initiatives are ongoing in terms of recognition and reward. They may shape these kinds of discussions, they may shift the perceived workload and job satisfaction. So these are all aspects that in the future can be referred back to this kind of baseline that we have now quantified. So for me, I think it is at the same time positive. It is positive to see how people perceive their job satisfaction, and that is something that we do very well in Carim, but we have to keep an eye on that workload. But, and that is something that I think is also important to stress, should you be in a situation where you at this point already consider that workload to be too much, then of course there are, with your supervisor, within Carim, with HR, and within a university as a whole, various contact points that you can already reach out to, because it is a topic that affects many of us and that we should keep an eye on. So with that, I hope I could give you a little bit of an overview of this. I hope it is something that sparks some further discussion for all of us, and well, that's something that we will come back to as a strategic board in the future as well. Thank you for your attention, and I'm happy to take any questions. Rory.
Very well done.
Good catch.
Yeah. So no, it's a really interesting presentation, and maybe I have a suggestion for a question in the future, and that is how much time or what percentage of their working time people perceive as productive, because yeah, I have the feeling that I have days where I feel very productive, and that's mostly when I'm doing research. And there's a lot of time that I spend in doing chores, which I don't feel productive at all. And I think it's a very good measure, and also maybe to see how to minimize the chores, the other component, because I think that's where the most gain can be made.
Yeah. No, exactly. And I think that the question on satisfaction probably comes quite close to that, because I think if we feel productive, we're probably quite satisfied with that task. So I think there will be some correlation there, but I agree it is it is also a matter of efficiency in that sense. So where you feel productive and where you can, that brings us back to recognition and rewards. Where can you contribute most and be the most productive? So I think it's a good point, and certainly something for a future survey to keep in mind. Thank you.
Just a quick remark. Shouldn't we redefine teaching, because there's a lot of teaching in research, and should you, well, you can take that from the survey now, but I think we put a lot of emphasis on research, but there's a lot of teaching in there, isn't it?
Yeah, and people like that as well. So of course these categories are very broad, and it is all self-reported and all sometimes difficult to define, right? There is management related to teaching, there is management related to research, and it all, there's a gray overlapping area where all of these meet. So this is not an exact science in that respect. And you can, and we do have, of course, we've asked people, what do you consider these other tasks, for instance, because that is, of course, a very broad group, and many people have responded to that. If you look into that, it does seem to be what we would really say management tasks. They don't seem to be, on average, the things that relate really to research or teaching. It does seem to be the chores that Rory mentioned, and so the other tasks that we all know. So we get a little bit of info there, but I fully agree with you. It is not exactly defined what is one and what is the other, and what's maybe too much for someone in one category, another person may have labeled in another category. That's very true.
No question, just a remark. I would like to thank you very much for this really balanced presentation of sensitive results. And also, as you really eloquently mentioned, high workload, very high workload, should not be considered always negative, because some people need it, endorphins with long distance runners. But when it's too high, then you should somewhere hit the bell. And we're all there to listen to everyone, because I think that's crossing a line. And really, like, on top of this, like in our whole institute. And thank you again, Jordi, for this excellent presentation.
You're very welcome.
Break. Back in half an hour.
Welcome back, everybody. Hope everybody made it from the rafter to here. It's both a pleasure and an honor to introduce Professor Mary Cushman for the Robert Reneman Lecture 2023. As a short introduction, I prepared some slides. Professor Cushman lives in Burlington and is a hematologist, medical director of the Thrombosis and Hemostasis program, and professor of medicine and pathology at the Robert Larner College of Medicine at the University of Vermont, as you all can read on the slide behind me. To introduce her, I would like to highlight 3 aspects of her career, part of it. Her science on thrombosis and hemostasis with a focus on epidemiology and stroke, her role as an editor for the journal RPTH, come back to that, and the contribution on diversity, equity, and inclusion. To start off with the science, and I hope you can read a busy slide, while I was preparing for this introduction, I started with the number of publications, but got a bit lost in PubMed with over 1,000 hits. And the first paper of Mary Cushman from 1940 on vitamin C. A quick Google search didn't help either when I found a book with the title, I Was Just Leaving, Reflections on Going Old. Could be better attributed to Paul Shiels, but it was from Mary, and I thought, did we invite the wrong Mary Cushman? So I Googled a lot more, and I don't know whether I have a pointer. Is that working? Anyhow, on the upper hill, on the upper part, you see the Google Scholar search, which showed an amazing 540 plus publication. And the lower bottom, you can see that she likes to write, but she has almost 14,000 X messages, the former Twitter account, so indicating that she likes to write. I'm not going to share more on her research. I'm convinced that she will do that during her Robert Reneman lecture. For those interested in her career, she has her own Wikipedia page, so Google her and you will find that. What I would like to focus on a little bit more is when she started in 2007 as an editor, as the new editor, or as the editor of the new journal Research and Practice in Thrombosis and Hemostasis from the ISTH, the International Society of Thrombosis and Hemostasis. And depicted on the graph, over the years, not only the number of papers increased, she did an enormous job of getting novel items in the journal, like the illustrated reviews, which she did with Alicia Wahlberg, which is a very hot or very often read articles in this journal. And again, bringing the Twitter, the X, to the journal, she linked the publication and the citation to the Twitter messages, the social media exposure, bringing something novel to that. But what I liked most on the RPTH, and where I'm going now in the short introduction, is her link to diversity, equity, and inclusiveness. While being an editor for RPTH, she has the editorial section used to her benefit, and on a very enthusiastic, engaging way, forced the editorial board to include as much women in the review process as you would do for the males, and bringing with that under the attention the status of women in science and in publications. And it's a small step to improvement. If you look at the graph, we see that over the years, slowly the number of women as first author, senior author increased over time. Small percentages, but step by step, we go to the area of 50% or even sometimes higher. With that, I don't know Mary that well from the research. As Tillman always like to say, we know Mary from the after parties. But with that, on the diversity, equity, and inclusiveness, I would like to invite you all tomorrow to the workshop discussion panel she is heading at 12 o'clock at the Department of Biochemistry. I understood from Tara that we had 25 registrations thus far. I think for a community of 240 scientists that we can do way much better. And I hope that we still have a lot of sandwiches, so come over and enjoy. Mary, may I invite you over for your lecture? And hope you will enlighten us on the science. Thank you.
Does that work? Is the mouse?
This is the mouse, and here's the.
Oh, there we go.
I see. Put in the pointer. And then it's there.
Thank you. Excellent. Henry, thank you so much. That was really thoughtful. I really appreciate it. So I thought you were going to talk about how much email I send you, asking you, can you please make a decision on that article? No, just kidding. So thank you very much. It's such a great pleasure to be here, and thank you for inviting me, and for all of you to stay all day for my talk. I've really enjoyed the day and learning more about the Carim. So I was thinking I should learn something about Professor Reneman, so I Googled him and found an annual report from the Carim. And he was interviewed in that annual report, and this was the advice that he had for young researchers. I'm very passionate about early career researchers. And he said, follow your own path, believe in yourself, follow your intuition, keep your eyes open, look at what the neighbors are doing. And don't become a one-trick pony. And, you know, the story of my career goes along with that. I'm a hematologist, but I do stroke research, and I love the methods of research. I'll study any disease. It doesn't matter. CKD, stroke, longevity, all of it. And it's just so much fun. And so this resonated with me. So we're going to talk about the commonalities of risk factors for cognitive impairment and stroke, and identify the role of biomarkers in the risk of cognitive impairment and stroke, and assess the potential for research in these areas to identify ways to improve brain health. So I will be referring to race differences in this talk, and the reference to race is in the context of the social determinants of health in the United States specifically. So I might discuss genetic markers more common in people of African ancestry, which are in turn more common in Black than white people in the United States. But this is the context with which we're studying race as it applies in the United States. So stroke, I don't think I need to kind of recite this to this audience, although I don't see stroke in your pillars, but it's the 5th leading cause of death in the US and the #1 cause of disability, affecting almost 1 million people every year. And it leads, as you heard in the last session, to cognitive problems and dementia. Dementia is also rising rapidly and affects 10% of those over age 70. And these two disorders have common risk factors. And I think of cognitive impairment and dementia as vascular diseases, as well as neurodegenerative diseases. So these are major risk factors for both disorders. They're the things I think everyone here would know. So I won't spend too much time on that slide. In the United States, stroke mortality is 2 times more common in Black than white individuals. And you see the graph on the left, which goes back about 20 years or so, and the top line are Black individuals in the United States. These are mortality statistics. And you can see over the last 20 years, while stroke in general has decreased, there has been no narrowing of the racial disparity. This is a persistent disparity that's existed as long as mortality statistics have been kept. So it's persistent and pervasive and unchanging. Dementia is also 40% more common in Black than white Americans, going along with what you might predict, considering that it has vascular origins. So we're going to go back almost 25 years. I got a phone call from a guy named George Howard. I had met him at a couple of scientific meetings, and he's from the South. He's got the Southern accent. And he says, do you think if we could get into the homes of 30,000 people all over the country, could you do anything with blood or get blood from them? You know, if we're going to do a study, an epidemiology study with no field centers. I said, yeah, I think so. I said, first, did you mean to call my mentor? You know, I was just an early faculty at the time and kind of late assistant professor. I said, did you mean to call Russ? Oh, no. He says, I want to work with you. I said, okay, great, so let's do it. So we wrote a grant to NIH, and we're fortunate to receive the grant. And this is the study, regards the reasons for geographic and racial differences in stroke. We started our funding in 2002, and the photos at the bottom are the current PIs of the study. So the PIs are at the University of Alabama at Birmingham, where Dr. Howard is, and he's depicted on the left, and Columbia University and myself at UVM. You can scan the barcode if you want to get to our website, or the QR code, I should say. So regards as a cohort study, so a classical epidemiologic study where we enroll a large number of people and assess baseline risk factors, all kinds of risk factors, as you can see listed on the left, and follow those people over time for clinical outcomes. And our grant was about stroke and race disparities in stroke, and also regional differences in the United States, which I won't be talking about today. But when they gave us the money, it was $24 million, and it was the National Institute of Neurologic Disorders and Stroke. And they said, well, we want you to add cognitive function testing, but we're not going to give you any extra money. And we're like, okay, we'll do whatever you say, because that's what you do when someone's giving you $24 million. And so we had to develop a telephone-administered cognitive battery. So we engaged a couple of neuropsychologists, was very helpful. None of us were really cognition researchers. We are now. And so we did that. And it was really important, as you'll see with some of the data that we're presenting. So we create this infrastructure, and then all of our colleagues find out, boy, they're doing this crazy thing. They're enrolling 30,000 people in their homes all around the United States. And so you can see the variety of other outcomes that have been collected because other people then wrote grants to get funding to ascertain other types of outcomes, and some of them are listed there. So in epidemiology, we're a very social discipline. People like to work in groups. They're collaborative. So I always say we work in herds. And this is a regards steering committee meeting in our beautiful building, which doesn't have wooden-topped lab benches. And yet at the beginning of regards, we were a large, simple study, and we had a really small group that sort of planned everything. Very different from the other studies I was involved with at the time, like the MESA study and the cardiovascular health study, big NHLBI observational studies that involved scores of investigators from different centers. We were center-free and had a lot of flexibility. So what we did was recruited potential participants by mail. We sent them a mailing ahead of time and then followed up with a phone call and did a baseline interview using a computer-assisted interview methodology, kind of like what telemarketing people use when they call you. They're reading off a script. We then followed that with an in-home visit. This was the challenge. We realized that there are companies that will go into the home and do a physical exam and draw blood. And these companies, their business was life insurance physicals. So you would apply for life insurance, they would send someone to your house. And when we realized these companies existed, that's when we realized we could do this study without field sites. So they trained 30,000 employees on our protocol, put them all through human subjects training, went into the homes one by one, and did examination, blood pressure measurement, collection of medications data, and drew blood, collected urine per our protocol. And my role was to organize the laboratory components and create a central laboratory-based biorepository. Follow-up occurs every 6 months by telephone, and stroke and cognitive function are ascertained. So this was the team at the start. We had a programmer, a program manager, a repository technician, and it was really exciting. And this is sort of what it looks like. You have the examiner in the home, and the blood was drawn. DHL was our shipper at the time. They were our company we used for home visits, DHL. They were DHL's largest client, so we got a good rate on overnight shipping. And the samples would come overnight with paperwork and an ECG to our lab, which is this building, in Vermont. And we would then unpack the samples. This is what it looks like when 100 samples come in one day. We had to create like a factory for unpacking them. Everything was barcoded and just reprocessed. So we had to spin them at high speed and then store them away or analyze them for baseline risk factors. This is kind of what the kit looks like. And then they go into our freezer farm, our warehouse. So at the baseline, we filled 24 chest freezers with about 500,000 aliquots, 750 liters of biological specimens. A lot of urine. Takes up a lot of space. So at the end of enrollment, after about 3 years, this is what we had, 30,239 participants covering nearly 2/3 of the counties of the US. The age was 45 and older, and a little less than half the participants were African American and half white. We excluded people who self-reported other race or ethnicity identification. And you can see there's a lot of people in the South, and that's because we oversampled in the Southeast to study the regional disparity in stroke, which is experienced by people who reside in the Southeast. So this is just gives you an idea of the baseline data that's available from the cohort. Everyone is geocoded, so we can link their residential address to all kinds of interesting data, like weather data and groundwater, whatever people are interested in. And you can see the numbers of outcomes for different conditions at the bottom of the slide. At this time, we have over 2,000 people who've experienced stroke. We get the medical records from their hospital where they were treated. And you can see the whole range of other outcomes that we have. So I'm going to give you a sample of things that we've learned. Because we share our data and give away our samples and are very collaborative, there have been over 700 publications from the study. And most of the people who are first authors of those publications have had no funding from the study at all. They're just people who come in and want to use the data. Before even the first information, we actually just did a very simple thing. Is the racial difference due to higher case fatality or higher incidence of stroke? That wasn't even known. So we learned that it was incidence of stroke. So Black people had a higher incidence of stroke. Their case fatality after stroke wasn't very different. But the striking issue was that this disparity by race was greatest in younger people. So you can see the relative risk here with increasing age, and it's the people in the youngest age group in the study that are most affected by this race difference. So this is really bad, right? Because I told you at the beginning that stroke is the #1 cause of disability. So what's happening is you're taking people kind of in the prime of midlife and experiencing this condition that has high disability. So really bad, as my colleague George says, it's really bad. So we looked at what is the impact of the difference in risk factors on this racial difference. So what you see here is a more scientific way to show what I just showed you. So you see on the left, the young age group with this relative risk of 3 after adjusting for demographic factors, decreasing over time. The dotted lines are the confidence intervals around that estimate. And when you add the risk factors into the model, you explain roughly half of the relationship. So the difference in the major risk factors for stroke in Black people compared to white people are explaining part of this. And hypertension was the most important driver, differences in hypertension. When you then, on top of that, add socioeconomic factors like income and education level, there was no further reduction. But of course, we know, and you just heard, that socioeconomic factors are really critical in the evolution of the risk factors to begin with. So it's not to say that it's not important. So basically, there's the risk factors, just to remind you. Half of the excess stroke risk experienced by Black people is due to these traditional risk factors for stroke. What about other factors? Here's a list of just possible other things. There's many things that could be explored. We have working groups of people who are working on a lot of these different issues. There's a whole built environment working group, for example, that looks at characteristics of where people live. And we have a newer structural racism working group that's very active and getting a lot of grants to think about the role of structural racism in this relationship. But getting back to kind of fundamental things, the blood pressure is a really critical issue, as I mentioned. And here we went on to look at systolic blood pressure on top of just hypertension prevalence. And what you see on the left is the relative risk of stroke per 10 millimeters of mercury higher systolic blood pressure. So it's about 14% increased. When you look by race, though, you see that in Black individuals, the relationship is greater. So blood pressure is a more potent risk factor in Black people compared to white people in our study. And when you account for all the other stroke risk factors, it basically holds. So systolic blood pressure has a 3 times greater impact in a Black person compared to a white person, a 24% increased risk for every 10 millimeters of mercury compared to 8% for a white person. So that led us, at the fortunate juncture of writing a renewal grant, because we have to write a renewal every 5 years, to say, well, why do Black people have more hypertension? Or why is it worse? And so we were able to get funded to look at that, and I'll show you a little bit about that in a moment. Parallel with this, systolic blood pressure was also strongly associated with cognitive decline in the cohort. We have this granular data on cognitive function testing over time, so we can look with great detail at the pattern of cognitive decline using different tests. And similarly, the association of blood pressure with cognitive decline was greater in Black than white individuals. Now we know from clinical trials like SPRINT and its sub-study SPRINT Mind, and recently at the American Heart Association, it's not published yet, but the China rural hypertension study, these trials have shown that intensive blood pressure control reduces the risk of cognitive impairment and dementia. And of course, we know it reduces the risk of stroke. So this leads to possible ways that we could reduce this racial disparity, better blood pressure control. So in terms of blood pressure, the incidence of high blood pressure, hypertension, we were able to get funded for our renewal. So we did a second exam. It took us a couple of tries to get that grant funded. So the second exam was 10 years after baseline. And the primary purpose was to keep in touch with the participants, to keep them in the study, but to detect incident risk factors. And of course, collect blood samples and urine again because that's what I do. So we had a very high participation rate. Over 16,000 people participated in the second visit, and we did really the same protocol as at the baseline visit. And we found, not surprisingly, that Black individuals had a twofold higher risk of developing hypertension over the 10-year period. And so we've done a fair bit of work to understand why that is. And what the risk factors shown on this slide are risk factors that we know are related to hypertension, so we wanted to look at those. And in this paper, which George was doggedly determined to get this paper published in JAMA, and the response to the review document was like 80 pages long, twice. I said, George, just give up. And he's like, no, I want it in JAMA. JAMA doesn't publish a lot of stroke papers, we've learned. They're much more interested in the heart. But at any rate, in this paper that George led, we looked at the association of risk factors with the excess hypertension risk in Black people. And we saw differences by sex. So here you see for men, the important factors were lower SES, poor diet, high dietary sodium, and inflammation. Whereas in women, adiposity was an additional explanatory factor. So this gives potential knowledge that can potentially help reduce the disparity in hypertension by really focusing in, for example, on healthy weight for women and sodium for men. And of course, the poor diet, as we heard about before, is important to everything. Tim Plant and our group looked in detail at C-reactive protein and incident hypertension. We measured CRP in everyone in the study as the samples came in. And he showed also a difference by sex, with 5% of the excess risk in women being driven by CRP and 15% among men. And when we accounted for the risk factors, much of this difference based on CRP was related to the risk factors. So we conclude from this that the inflammatory effects of the hypertension risk factors are what are important in the pathway to hypertension. Diabetes, of course, also a major driver of the race difference in stroke. It's higher in African Americans and drove that stroke risk difference and explained 20 to 40% of the racial difference in stroke. And Black individuals in the study also had a doubling of their risk in diabetes over 10 years. And the main mediators of this that didn't differ by sex were adiposity actually did in women, similar to blood pressure, but lower SES and poor diet were critical. And my student, Brittany Palermo, who just had a baby the other day, she has shown major relationships of baseline IL-6 levels with the risk of incident diabetes, which did not differ by race. And again, a similar idea, inflammation is bad, and it's bad for glucose metabolism. Hopefully that paper will be coming out soon. We had a revision decision this morning at a prominent journal, so we're hopeful. Brittany had never done research before. This is the great thing about working with students. She was afraid. And I said, don't worry, we'll teach you how to code. And we do a boot camp in the summer for medical students to come and work in the lab for the summer after their first year. And she was top of the group. So if you're a student, don't be afraid to code if you have a good teacher. So to summarize, the risk factors I've discussed explain half the racial disparity in stroke. Blood pressure was critical. It's the triple curse. It's more common in Black people. It requires more medications to get it in control, and it's more potent as a risk factor. So maybe we need to consider different treatment goals, and certainly primordial prevention of hypertension in the first place through lifestyle modification, but perhaps anti-inflammatory therapies. If we can understand the origins of the race differences in the risk factors, we may be able to do even better, other novel pathways. So we have this glass half full situation where about 50% of the disparity is related to risk factors, and what is the other part of this for stroke. And we hypothesized that lab biomarkers could identify reasons for the racial difference in stroke. And there's two ways that we could do this, that we could determine this. One would be that the risk factors are mediators, that they're in the causal path, and also that they're moderators, meaning that they might be more related to stroke in one group than the other, or race-specific risk factors, if you will. So we've had a lot of different people, students and faculty working on this in Vermont. That's kind of our role in the study, is to lead this sort of work. And we're so proud of all of them. We designed a case cohort study, and this is within an epidemiologic study, you embed this design. And rather than measuring the biomarkers on everyone in the study, we measure them in people who developed the events of interest and in a random sample of the entire cohort. So in this case, our design included 650 people who developed stroke over the first 5 years, and 500 people who developed cognitive impairment during the first 5 years, and a random sample, which is kind of your control group, sort of 1,100 people. And we measured a whole array of biomarkers, and I'll just show you some examples. There can be genetic-related markers, like sickle cell trait or elevated lipoprotein a, and circulating proteins representing inflammation, organ dysfunction, coagulation. And metabolites. We have a guy at Mass General, a vascular neurologist, who got funding to do metabolomics profile in these participants. So sickle cell trait is really fascinating. It's found in 8% of Black Americans. And we first learned that sickle cell anemia is a prothrombotic condition, and then that sickle cell trait, the carrier state, is also prothrombotic, and then further that these two conditions are risk factors for venous thrombosis. And I say race-specific just because it's more common in people of African descent. It's not seen in other groups, but they are risk factors. And the hypothesis for this relationship with venous thrombosis is that the venous valve pockets are very hypoxic. The PO2 in the venous valve pockets is like 45. And so the hypothesis is that the red cells of a person, even with sickle cell trait, can sickle at that low O2, and that causes a prothrombotic tendency and elevated levels of circulating biomarkers like D-dimer. And so that's the hypothesis for why this is. So we wondered, well, maybe this relates to stroke as well. If it's prothrombotic, it could be driving coag activation and stroke. So we collaborated with other studies listed on the slide to do this meta-analysis of sickle cell trait and the relationship with ischemic stroke, and there was no relationship. So it kind of bolsters the hypothesis a little bit about the venous valves, because you don't have the same kind of situation in the brain, not in the arteries for sure. And so that was interesting. And Christina Cahill, who was a medical student with me, wrote this really nice paper on sickle cell trait and cognitive impairment using that case cohort study framework. And we also saw no association with cognitive impairment. So these are just example data from that paper on the trajectories of different cognitive function tests by sickle trait status. And you can see the lines are just completely overlapping for the two tests that are shown here. So lipoprotein A, it's an atherogenic particle that includes an LDL-like particle and apolipoprotein A. It looks like plasminogen. It promotes pro-inflammatory pathways in atherosclerotic plaques and is thought to enhance abnormal clotting. It's mostly genetically determined, the levels, and 1 in 4 people have what you might call high levels, and it's much more common in black individuals than white individuals. So it was a candidate for us to think about whether it could contribute to race differences. We think the race difference is likely due to genetic ancestry. So in our first paper on this, we showed a pretty striking relationship of higher LPA with stroke risk only in the black people, not the white people. Now, many of you know that there are pharmaceuticals in development to lower LPA specifically, and this pattern has not been seen in studies of coronary heart disease. So maybe there's something different about stroke related to LPA that gives us this pattern. And interestingly, along with this, we saw the same pattern for cognitive impairment. The relationship was less strong, but also different and exclusive to black participants, not white participants. So we could conclude that it's a race-specific stroke and cognitive impairment risk factor. And with the new agents that are in development, one might hope then that the clinical trials testing these agents include sufficient numbers of black participants so that differential treatment effects might be observable. I don't know if I'm optimistic about that, but we can hope for that. And maybe that they should be assessing cognitive function in these studies. It's not a typical endpoint in cardiovascular trials, though, but it probably should be. So the next topic is on inflammatory cytokines. And this paper was accepted by Neurology, and they said, we're gonna make an infographic for your paper, because we like it. And I thought, oh, that's cool. So they hired a company to make this infographic. And as Henry knows, and some of you might know, we do the same thing for RPTH. We use the same company, but I got the idea for that from this paper, and they made this really nice, it's a little busy looking, but a nice infographic. So we measured IL-6, IL-8, and IL-10 in the baseline samples of the case cohort study. And you can see here that IL-6 was the only of the three that related to stroke risk, and quite substantial effect sizes. IL-6 in the top quartile of the population distribution was associated with a doubling in the risk of stroke after adjustment for the other major stroke risk factors. When we looked at whether IL-6 mediated this racial difference in stroke risk, I'm showing it this way because it's just easier than the complicated tables. What we found was similar to what we had seen for hypertension, that it appeared that the inflammatory effects of the risk factors were important in the racial disparity in stroke. And so again, suggesting inflammation lowering could be helpful in this regard. And you could do that different ways, like weight loss, statins, other sorts of interventions. So the inflammatory effects of risk factors are important here for stroke as well in terms of the racial disparities, and perhaps inflammation lowering through whatever means, weight loss, diet, healthier diet, physical activity, medications could reduce racial disparities. We're doing similar work now on cognitive impairment that I can't share because it's not done yet. So from this study, we've looked at a variety of other markers. I put some here that I thought might be interesting to you. So we estimated non-alcoholic fatty liver disease using something called the Fatty Liver Index. It's a measurement that uses GGT and lipid levels to classify people. It's a pretty well-validated metric. And we showed that no real relationship with stroke, but for cognitive impairment, people with NAFLD had a doubling of the risk independent of other factors. And that relationship was highest in the younger people, which was really interesting. We see a lot of cognitive change in this younger group, even though you wouldn't think they're impaired. You know, some of us who are in that age group think, oh, I'm not thinking quite the way I used to, right? And when you have thousands of people in your study with a battery given every 2 years, you're detecting declines and risk factor relationships. It's really the most important subgroup, I think, in the study, because that's when cognitive impairment starts. And NT-proBNP for the cardiology people in the group was very powerful predictor of stroke risk, a tripling of the risk for NT-proBNP in the top quartile. Presumably this is related in large part to atriopathy, people with a sick atrium who are perhaps predisposed to cardioembolic stroke, whether they have AFib or not. And indeed, the hazard ratio was 9 for people with cardioembolic subtype of stroke. So very, very strong relationship. A lesser but similar relationship with cognitive impairment. You can see they're mostly mirroring each other. And then blood group for the coagulation people in the audience. Blood group relates to lots of things, including procoagulation, like higher factor 8 in people with non-O blood groups, but also to levels of circulating adhesion molecules and so forth. And in this analysis, we showed that those with blood group AB, who also had the highest level of factor 8 compared to other blood groups, had greater risks of stroke and cognitive impairment that was partly mediated by factor 8 levels. The cognitive impairment paper with blood group got media attention that went on and on and on because people, it was just like sexy, right? So your blood group links to cognitive impairment. You know, we were getting emails from people thanking us for saying, you know, I have blood type AB. Now I understand why I can't think right. You know, it's like, okay, thanks. But really interesting work. And then the last example here in the case cohort study is this piece about metabolites that I've been showing you. So Taylor Kimberly is the neurologist that I mentioned, who's been doing just great work. And I just have such a great fortune to work with his students and help them write their papers and help them understand the study. And he developed a metabolomic profile and measured this in this subset of participants and showed amongst 162 metabolites, gluconic acid was strongly associated with baseline hypertension. Gluconic acid is a diet-related oxidative stress marker, thinking of it simply. And he then went on to show that gluconic acid levels were a stronger risk factor for stroke in Black than white people, perhaps reflecting some of these things that we've been discussing and that you were discussing earlier. It explained about 25% of the association between hypertension and stroke. So based on what I told you before, that would seem really important, right? And maybe relates back to that George Howard JAMA paper about the factors that contribute to race differences in hypertension. And the factors most related to gluconic acid were poor diet, lower education, and low physical activity. So again, information of help to those of us who struggle to maintain our healthy lifestyle. So the last kind of piece of data I'm going to show you is a work in progress, and we had some extra money in our budget, and one of the things I really wanted to do was look at stroke risk and AFib, because we know that anticoagulants are effective, but we know that there's residual risk even with anticoagulants. And we had 2,400 people with AFib at baseline. So we measured this whole variety of factors in those people. And this was just presented at the American Heart Association by a student. And you can see the biomarkers listed here. I'm obviously not going to go through all of them. And you can see them lined up here in the order in which their associations were greatest. So here's the hazard ratio of 1. So if the dot is above this imaginary line right here, there's a higher risk associated with that biomarker. And you can see NT-proBNP, GDF15, lipoprotein A, cystatin C, which is a measure of kidney function, IL-6, and galectin-3 were risk factors for stroke in this AFib subset. All these people in this analysis were not on anticoagulants. Only about 23% of people with baseline AFib were on anticoagulants at baseline. And Sam Short, the student who's working on this, went on to see if addition of these biomarkers to the CHADS-VASc score which physicians use to decide who should get anticoagulation and who doesn't need it, he showed that they improved the ability of CHA2DS2-VASc to predict stroke risk. So this is really exciting, because if we can better identify the people at highest risk, then anticoagulation, which has substantial toxicity in terms of bleeding risk, might be better employed in that population. So hopefully he'll be getting his paper submitted soon, and you can all see all the detail on that. So to summarize, some of the biomarkers we studied underlie the effects of traditional risk factors on stroke, like IL-6 and CRP, which are correlated with each other, of course. Some are race-specific stroke or cognitive impairment risk factors, so they hold promise for reducing disparities. Some didn't relate to stroke or cognitive decline, which I think for the sickle trait is really important for that community to know that it's not relevant to those outcomes. Of course, it's relevant to venous thrombosis, and it's also relevant to end-stage kidney disease. So really important for people to be aware of their status. Not all people are aware. And then some of the biomarkers suggest possible new treatments to improve brain health, and I list some of them here that could be useful. And I think with the tidal wave of non-alcoholic fatty liver disease, it's going to pour into the tidal wave of increasing cardiovascular death rates that we're starting to observe in the States. After 20 years of decline, cardiovascular death is starting to rise again since about 8 or 9 years ago. So I hope I've shown you that we've identified some actionable steps that might improve the health of Black people in the United States around prevention of these common conditions. And that, as I mentioned too, I hope that clinical trials will sufficiently represent these people who have greater risk. I've talked to some people in the pharmaceutical industry who say they promise they're doing that, but we'll see if they can come through. Because if we're not studying the groups at the highest risk of the diseases we're trying to prevent, then we're not doing justice to our patients and to the public. And then our ongoing research, I alluded to structural racism. And so, in the US, structural racism goes back to slavery and then unjust policies in the early 20th century around where people are allowed to live. There was a policy called redlining where they literally drew circles in cities and say, these are where Black people can live, and we're not going to give mortgage loans to Black people to live in other places. So they controlled where people were. And these policies have been shown to be related to health disparities even now. So my postdoc, who's soon to join our faculty, is really engaged in this work and trying to understand the biological embodiment of structural racism and how it fits into all the things I've been telling you. So she has a great career ahead of her in that area. And we are currently classifying dementia in the study. We can't do full neuropsychological testing in several thousand people when we don't have any clinics, and we can't afford to do it. So Jennifer Manley, who leads our cognitive research now, who's at Columbia, is doing this really cool thing where she's sending people into the homes of selected participants to do neuropsych batteries, and then they're being adjudicated at her Alzheimer's Disease Research Center. And she's going to use that data with all the data we have longitudinally on these participants to create an algorithm that will classify the entire cohort for dementia status. It's really cool. And she's done this successfully in another study, so it'll allow us to really look at the something deeper than being impaired. Our cognitive impairment definition, it's kind of like mild cognitive impairment or MCI. And then more on the stroke and AFib, I think, will be really exciting. And we're always, like I mentioned, welcoming collaboration. So if there's anything I said that fits into what you do or you have ideas, I'd be happy to speak with you about collaboration in some way or making data available to you, even if it's just to write a paper. Happy to help. I listed some of the really key people involved with the work that I described today. This is the view from my patio at my house. If you follow my Twitter account, you'll know that I like to post pictures of the sunset. I started doing that during the pandemic when we were all stuck in the house because there was so much bad going on. And I live in such a beautiful place. Just wanted to share it. And so now I have a reputation for like being the sunset lady. But I took this picture during the pandemic and it stuck with me as just a beautiful representation of the wonderful place where I'm privileged to live. And this is a photo of one of our pre-pandemic regards investigator meetings at the University of Vermont in our beautiful research building. And we haven't had a chance to be together like this since the pandemic. We're hoping that our grant will get renewed this year so we can have the funding to be able to do this again. Usually we meet pre-pandemic about once a year with a broad group and we bring all our students and it's just great fun. This is my clinical family, so that's my research family. This is my clinical family at my house. We had a retreat last summer and my donkey friends from down the street came for a visit and it was a great lunch break for the group. We are celebrating our 20th anniversary as a clinical program, which is, I don't know where the time went. And this is my family. And I wouldn't be anything without my family. Sorry. This was from Thanksgiving last week. We had our grandchildren and children to our home for the weekend, and it was really fun. So I'd be happy to take questions if anyone has them. Thank you for your attention. Oh no.
Fabulous talk.
I said gluconic acid.
I'm so glad I've been exposed. That was such a good talk. With regards to structural racism and redlining communities, have you thought of looking at the interface between where the line is and the adjacent community to see if that's where some things happen more frequently? And with respect to the internal part of a red line community? Well,
so that's the idea. So there's many proposed ways to measure structural racism. And the research community is really just starting to learn this. We're learning so much from our social science colleagues, especially. And of course, we're going to compare people who reside in those areas to people who didn't. And you could use spatial analysis to get really deep into it, and we can do that. We have people's residential history going back to birth. So one of our baseline questions on the computer interview, we call it, where have you lived? And so for each participant, just went back, reverse chronologic to their birth. So we know where they've lived their whole life, because it's not just where you live now, but where you lived before at different phases of your life. So and one of the really cool papers by Virginia Howard, published out of Regards, she looked at the stroke belt, the southeast hotbed for stroke, where stroke risk is higher. And what she found is if you were born in the stroke belt and grew up there and then moved away, you still carried that risk with you. So it points to the things you were bringing up about your early life exposures that are so important.
Obviously, you have got a blood set that allows you to look at the microbiome again and signatures that may be affecting it. And the thing that struck me, certainly resonated with what we have been doing, is our deprived communities often live on contaminated land. Looking back to heavy industry 150 years ago, 250 years ago, and they carry a health legacy as a consequence of that. And typically, if you look at higher incidence of stroke within the UK, again, it's always among those that are most socioeconomically deprived, though we don't have the same ethnic disparities as you would have in the US. But you have a really powerful tool for analysing that.
Yeah, there has been some research on trace metals, so measuring in blood and urine trace elements, and a whole bunch of papers published on different ones, which relate to also the contamination of the soil and water where you live. And so it's endless, the things you can think to do, especially when you have people geocoded and you know their residential history over time. You can link to so many different resources. We had a study on sun exposure and how sun exposure affects stroke risk, for example. And it's just fascinating. And so there's something for every kind of scientist, really, which is our goal, is to get a lot of people, a lot of grants, bring in a lot of money, and learn some things that are really important, using measured risk factor data. Yeah.
Thanks for your great talk and amazing set of data. And so one question is about genetics. I mean, we know there's a lot of genetic differences between these races for blood pressure, for the renin-angiotensin and for LPA, what you mentioned. So how about data and analysis on that? That's one part of the question. The other part would be, the challenge here really is to improve health. And so the black people have an increased risk of getting stroke and CVD in general. And improving lifestyle and CES is not so easy. And giving medication for diabetes, hypertension, lipids, inflammation
or
is also not the solution. Right? So what are your thoughts on that?
Yeah, so we have, this, I could give a long answer or a short answer. So we have genomics data. It took a long time for us to get it because the study is so damn big. So to do a GWAS, it was unaffordable. It was difficult to, we're writing investigator-initiated grants. It's very competitive. We cannot put it in our core funding because the research already is, tens of millions of dollars every 5 years. And so on our first renewal application, we had aim 3 to isolate DNA and make it available to the research community. So this was around 2005 or 6. And the reviewer said, no, that's not science, take it out. Because the DNA extraction is $30-something a sample times 30,000. It's a lot of money. And the people reviewing the grants are all different kinds of people. And, they're not supposed to consider budget when they consider the science. So we had a lot of trouble just getting the DNA. And so over time, we were able to eventually have GWAS on all the black people, not the white people yet, but we're doing that now. The NIA has come in, the National Institute on Aging, and they're very interested in our study, and they have funding, especially for Alzheimer's research and dementia research now. So they're actually doing GWAS for us and paying us to extract the DNA and all the rest of the people. So we'll have that in a year or two. So there's a lot of papers on different aspects of it. Stroke is a little difficult to study the genetics of because it's a heterogeneous disease. There's the different subtypes, and so it's a little difficult, but there are papers out there. I think some of the most important work we've done is on ApoL1, kidney risk variants affecting black people, and how important they are in renal health, for example. So there's a whole variety of papers, and our genomics working group is now called the Multi-Omics Working Group. And we're trying to get funding, different investigators are trying to get funding to do DNA methylation and other kinds of omics. We just got a proteomics grant funded for cognitive impairment. So that's just about to start. Once they decide to activate it, it's like, yes, it's got a fundable score, but until we have the money, you just don't know with NIH. So yeah, so there's a lot been done and much more to come, hopefully. But yeah, that bump at the beginning was a major impediment to the progress. Because we're involved with the CHARGE consortium for our other studies, but not regards. So it's sad.
Hey, tremendous enterprise you showed us here. So in any variable or pathology that you studied, black people are at a disadvantage, which is actually a pretty poor outlook. But does this mean that they're just all connected and maybe track back on socio-economical status alone? And if yes, did you consider a sub-analysis just in the black population, separating higher and lower socio-economic status?
Yeah, we can do all of that, yes. So, and I mean, socioeconomic advantage is protective for everybody, for sure, yeah.
But like if you then were like peel apart, like being black, or is it mainly socioeconomical status?
Yeah, it's not because you're black, it's because you have the experience of being black in the United States. Right. That's how we interpret, I mean, there's ancestry genetic differences, like APOL1, it's just a great example. But I think the environment is probably a lot more important to this.
So you could compare same socioeconomic status, black and white?
You could.
Would you expect a difference?
Well, and you sort of do that when you adjust for socioeconomic status and see whether the race difference persists or, yeah.
Thank you very much. One more question? Okay. I'm not going to throw at you, Harry.
While you're doing that, I'm going to take a picture. People want to, like, I'm going to take a picture for my Twitter feed. So, say hello. Yay, okay. See, now the Carim will be, like, spread around.
Yeah, one more question. Related to the excellent data set you must have collected, and congratulations with that, quite impressive. In the first part of your talk, you at several moments referred to poor diet as being a factor. Now, one of the most difficult things in studies like this is probably to define poor diet. Have you made sub-analyses on what factors in that could be the most important one?
I can't wait to answer your question. So Suzanne Judd, who is the current contact PI for Regard, she started with us as a fellow, and now she's in charge of the whole thing. And Suzanne is a nutritional epidemiologist, and we collected food frequency questionnaire data at baseline. So when the examiner was in the home, they left paper questionnaire called a food frequency questionnaire. How much of this have you eaten in the last 2 weeks? That kind of thing. And she took that data and used factor analysis to identify dietary patterns and created new dietary patterns. And of course, we have the Southern diet, is what she called it. And the Southern diet is the worst diet. And it is high fat, organ meats, fried food, and sugary beverages. They cluster together. And the only fish these people eat are fried fish, like McDonald's, basically, the fish sandwich. The fish sandwich is like a very prevalent thing. And so that Southern diet is a risk factor for all of the things I talked about, and of course has an adverse biomarker profile as well. Now, many of us in the team have what we call the faculty diet. The faculty diet is otherwise known as alcohol and salads. We don't call it alcohol. We don't call it the faculty diet in the papers. It's called alcohol and salads, but they cluster together too. So
we have 2 more questions from the younger ones, so we give them the time.
Oh yeah, beautiful talk. I could ask. I would love to actually spend an evening just picking your brain on the race disparity and kind of like your ideas and how kind of this story came to being. And if I may pick on one particular aspect, that being with the age that you mentioned at the beginning, that there's 3 times higher prevalence in black people for stroke, and being aware of the kind of contrast between healthcare systems in the US versus in Europe, or in the US you could even say lack of healthcare systems. So with the endless correlations you can make, is it known with the individuals who experience stroke at 40 whether or not they even have a primary physician that they can visit, what kind of healthcare they've experienced in their life or lack of?
There are a lot of people working on those kinds of questions, and we have data. I can't recite all of it to you, but we have a questionnaire that was asked about people's relationship with their doctor. And I think black people in general have less trust in their doctor. And they have more barriers to transportation to see their doctor. And so there's a whole group that works on this kind of stuff, but we have data on that. And then there's other people who've done work on healthcare utilization using linkage to other data sets. We have the social security number, so we can link people to other data sets as well. Yeah.
One final question here before we can jump into half-hour faculty dinner.
Yes, thank you very much. First of all, really interesting and also very important topic, so really thank you for the presentation. What I was wondering, in the population that you studied, did you also look at any differences in their knowledge on how to detect a stroke and the first aid that they need to perform? And if there were any differences between the different race groups? That's
a great question. So awareness, we haven't done a ton on that. So, I think awareness of stroke symptoms is less in lesser educated people and people who have less healthcare, for sure. So we did do something really interesting, though. So when they get called every 6 months, they get a questionnaire given called the Questionnaire for Verifying Stroke-Free Status. This doesn't really answer your question directly, but that's how we decide to go after medical records if they say they've had stroke symptoms. And we have this phenotype in the study that's not uncommon, that people report stroke symptoms, but they were never seen for a stroke. And some of these are strokes, some are TIAs, some might be complex migraines, but the presence of stroke symptoms clearly relates to the risk of future cognitive impairment and stroke. And so it's a whole line of really interesting research. People who report stroke symptoms have higher NT-proBNP, for example, and other biomarkers. So it's really an interesting area you reminded me about. We talked at one point about trying to do an intervention to educate people about stroke symptoms, but we never did it. And we asked them every 6 months. So we think that they are attuned to it. But the interesting thing about awareness that we showed, at the baseline, in any study like this, you wait till people get sick, and you have to write papers if you want to get your grant renewed. So we wrote a lot of kind of cross-sectional papers using the cross-sectional data. And we hypothesized that Black people would be less aware of their risk factors. So we measured blood pressure, right? We measured glucose. And we also asked people, do you have hypertension? Do you have diabetes? And for hypertension, we found that Black people were more aware of their hypertension than white people. It was very interesting. It was the opposite to what we expected. So something is happening that's right, that people are getting screened and diagnosed and we're aware. Because a lot of people, when you go into their home and measure their blood pressure, it's high, but they don't tell you they have hypertension because maybe they're not getting care or their doctor isn't paying attention or what have you. But we were surprised by that and reassured. So in that regard, they were actually more aware than white people, yet they still had these greater relationships with stroke.
Thank you very much, Mary.
Thank you.
So the Robert Reneman lecture comes with a priceless bronze of our famous Dutch sculptor Cajus Spronke. And I do realize that this will double the weight of your carry-on luggage, but Henry and I will now hand this to you.
Oh.
Maybe you can help me carry this.
Don't drop it on my toes.
And with that, there's also a little plaque which you can choose to put on. And there's your name, the year, and the...
Thank you.
Yeah? It's your choice.
Thank you so much.
Thank you.
That's so nice.
Good.
Thank you.
So with that, we come to the concluding session. And this is the section Carim Priority Prizes. And in the morning session, I already introduced to you the HS BAFTA. And this year we had several rounds of the several versions of the HS BAFTA, and the recipients of the HS BAFTA are already known with the recipients, because this is an annual process. But now, during our annual symposium, we would like to award the medals that are belonging to this high Carim talented awards. So with that, I would like to call forward for the pre-PhD BAFTA's Daria Macher and Jessim Kaya, for the PhDs Aaron Eiding, Eline Berends, Ellen Denissen, and for the postdoc Amé Buzio. And I know that they're not all present, but their representatives can come forward and pick up their BAFTA medals. Harry, can you come forward as well? So they come in different flavors. You can see there are different patinas, and there's also one bling bling variant. If you have a special desire for one of them and it's not there anymore, if you want to pick it up, you can come to the bureau and you can exchange it. And then take your pick, and then we make a yeah? We'll make a group picture in the end. Make a line up, Harry, you on one side and I on the other side. Please, you come in the middle. Is it okay? You want 2 lines? 2 lines? Then we will next proceed with the poster awards. While the posters were being displayed and presented, there was this jury going around. You probably have recognized them by the white binders. They interviewed you, and we asked them to look at the layout of the poster, which is of course very important, not too much text and a little bit of more white room. Also the content, which is some kind of important, we think, but also the presentation, and that was the most important part. And with that, there were some winners, and each division, blood, vessels, and heart, will have its own winner. The jury members are shown here. For the division blood was Carla van der Kalle, Sebastian Fouquier. For the division vessels, Paula van der Meijden and Constance Bate. And for the division heart, Yvonne Henskens and Roger Veldrop. And of course, obviously, all these jurors are not from that division. So I would like to have a big hand for all the work that the jurors did. For the division blood, I would like to call upon the winner, Titus Lemmens.
For the division vessels, I would like to call upon Sabine Damen. And then finally, for the division heart, Job Stocks, single author. He's a single author, actually. So, moving toward increasing importance, we move on to the Carim Thesis Award 2023. And I got a jury report, which is, I think, like 4 or 5 pages. So, next year's we might want to try to make that a little lighter. First, I would like the jury, Paul Volders, Marleen van Gevenbroek, and Judith Kozemans, for their excellent work. They really have to work through really a pile of theses every year, which is a lot of work, and it's an extensive report which I will read. But because I will probably give away the winner pretty soon, I'll just move on and show the slide and congratulate Dr. Rob Holtakkers.
So Rob is receiving the prize for his PhD thesis, Visualizing the Invisible Dark Blood Late Gadolinium Enhancement MRI for Improved Detection of Subendocardial Scar. You can see it's nice black thesis here, and you can see in the middle after a very successful public defense. The jury report. Enthusiastic, proactive, and equipped with a critical mind are only 3 of the qualifications that characterize this year's winner, Rob Holtakkers. In his PhD thesis, Rob describes the physical principles of magnetic resonance imaging and, in particular, the development of a novel method that increases the scar-to-blood contrast in the heart called dark blood late gadolinium enhancement. Whereas his background in medical engineering at the Eindhoven University of Technology could have primed him to scrutinize the technicalities of his investigations, he rather went on to implement his 3D MRI method in the clinic, and with great success. In the judgment of the Carim Dissertation Award Committee, this PhD thesis contains many aspects of excellence. Rob examined feasibility issues, provided histological validation in a translational manner, developed clinical application, and included 4 clinical case reports in which his methods were used. And in most of these studies, he was the front man, and by his efforts, his novel approaches became directly applicable on MRI scanners worldwide. Without the need of adapting local systems or installing software, thousands of patients per month in numerous hospitals benefit from Rob's scientific and clinical advancement. Whoa. That's quite a load you have to hear in the back. Not only did he prevail individually, he also proved to be a team player. And as an example, the introduction of the interventional MRI at the MUMC Plus, to which Rob contributed significantly, was awarded the 2022 NWO Team Science Award. Besides, many more scientific awards, fellowships and recognitions were presented to him. And there follows a list of like maybe 10 or 20 prizes, which I will not mention, Rob, because otherwise we'll stand here for another minute. But I congratulate you from the deepest of my heart with this fantastic prize. prize, but it's very sensitive, so you have to wrap it in plastic again. Be very careful.
And then I would like to invite Carim for the next procedure of drawing the members for the Carim Executive Board 2024.
A long time ago in Florence, when the Medici didn't reign for a couple of years, they invented a real nice way to steer the city's council, and that was by drawing. So every couple of months, just people from good standing, from all the guilds from Florence, were put in a bag, and then people were drawn from that bag, and they would serve for a couple of months on the city board. We thought a couple of months would be a little bit short, so we chose the way of adding to the executive board for a year. And as you can see that like all the boards like in ancient Florence really are parallel with the structure of Carim. So like the strategic board, the Carim PI groups, the school council, everything is the same. So actually we selected all our members in good standing and then we put their names in these little baggies. And you can see that on the next slide. Currently, we have 580 Carim employees. Half of them are PhD students, and they, of course, are excluded from this draw because they don't have a permanent contract. So in the end, we have 246 paid employees, from which then are in the bags 95 males and another bag with 60 females, of which 110 are scientific personnel and 45 are support staff. And from each of these bags, Carim will now draw 3 badges with names. And depending on if number 1 will accept the important task of the addition to the board, we will leave 2 and 3 and put it back for next year. And if 1 doesn't accept the important task, then we'll take 2 and so on. So I think now we'll just open the bags. There's 1 key, and then we'll start drawing.
insights that we do not expect from the current board members, so this is a great success. We're going to continue this, and we'll let you know who will accept the dots. Thank you, Nico. Okay, now the last. The last is the prime prize of Carim, and this is the Carim Commitment Award. So this is not only for persons within Carim that are of high scientific standard. This is the people that breathe Carim, that are committed to the functioning of Carim in all these ways: management, support, organization, etc. And I'm so happy to see that today's nominee, or actually recipient, is here, because the committee that chooses or selects the candidates is very secret, so you can't find them, you can't influence them, but they really know what's going on in Carim, and I'm happy that she is here today, because it's always a surprise, because they might not even register, so they're not informed. Commitment is her middle name. She does a lot within Carim. She is part of the strategic board, which she works very hard. She also works in Scrum as one of the important contributors to this novel technique that is really pinpointing the future of Carim. She was instrumental organizing the support staff within Carim to sort of a group that is similar to the I'm Carim group. And also, she's our court photographer, photographing like all the important stuff that goes on in Carim. So with that, I would like to call forward our, this is the previous one still. This is the draw. These are all the names that are in the bags. It's getting late for the director as well. We have to wait until the smiles, okay. Sandrine Seijen. And as you say, from the heart, because you care. And last but not least, I would like to thank our great ladies from Carim, Barbara, Tara, and Esther, for organizing this day again. And for everyone, especially, I would like to support Barbara, like in all the stuff that will happen to her and her challenges in the future. She'll be absent for a couple of months, and hopefully she'll be back in great and eternal health. Thank you all very much. This concludes our Carim Day, and we now can move to Thyssen to have some pre-dinner drinks. And for those who go home, safe travels, and see you across the street.